네, 안녕하십니까. 지금부터 2024년 스노우메드시티 한국주도 심포지엄을 시작하도록 하겠습니다. 오늘 이렇게 바쁘신 가운데도 귀한 시간 내주셔서 참석해 주신 여러분들께 진심으로 감사드립니다. 저는 오늘 이 특별한 심포지엄의 사회를 맡은 대한의료정보학회 이사장 최인영입니다. 반갑습니다. 네, 오늘 심포지엄의 주제는 How can we implement SNOMED in Korea입니다. 한국에서는 최근에 의료 데이터의 상호 운영성에 대한 논의가 많이 이루어지고 있습니다. 바로 이런 상호 운영성에 있어서 보건의료 분야의 핵심 과제로 저희가 스노우메드시티는 그 중심에 있다고 생각을 하고 있습니다. 이번 심포지움은 한국과 해외 전문가들이 모두 모여서 정책, 활용 사례, 그리고 이 모든 것이 잘 적용된 최신 기술을 공유하며 한국에서의 상호 운영성이 잘 구축되고 확보될 수 있도록 논의하는 뜻깊은 자리였으면 좋겠습니다. 오늘 심포지움은 Policy, Implementation, Technology 이렇게 세 개의 세션으로 구성을 하였고요. 훌륭한 연자분들을 모시고 저희가 발표를 들은 이후에 심포지움의 주제에 걸맞는 스노우메드시티가 과연 한국에서 어떻게 잘 적용되고 활용될 수 있을지에 대해서 패널 디스커션으로 마무리하도록 하겠습니다. 순서를 시작하기 전에 사실 오늘 이 행사를 보건복지부와 보건의료정보원에서 정말 오랫동안 준비를 해주셨고, 사실 인사 말씀을, 보건복지부 고용호 국장님과 보건의료정보원 연민섭 원장님께서 해주시기로 하셨는데요. 지금 국회에서 국정감사가 이루어지고 있어서 두 분께서 모두 참석하지 못하였습니다. 그래서 너무 죄송하다는 말씀 전하셨고, 또 다시 한번 이렇게 자리해 주셔서 감사하다는 인사말 전달해 주셨습니다. 네, 그러면 이 행사를 축하해서 해주시기 위해서 오신 저희 귀빈분들이 계십니다. 다음으로 축사를 진행하도록 하겠습니다. 네, 먼저 대한의학회 이준우 회장님을 모시고 축사를 듣도록 하겠습니다. 큰 박수 부탁드립니다.
네, 안녕하세요. 방금 소개받은 대한의학회 회장 이진우입니다. 먼저 대한의학회가 뭔지 잠깐 말씀드리는 게 좋을 것 같은데요. 대한의학회는 아카데믹 메디슨을 추구하는 대한민국의 학술단체로서 의학에 관련된 모든 학술단체들이 저희 회원으로 있습니다. 그래서 193개 학회가 저희 회원으로 있는 총 연합체라고 말씀드릴 수 있겠습니다. 아, 뭐, 축사를 시작하기 전에 말씀드리고 싶은 것은 여러 가지 이제 대한민국 의료가 글로벌하게 굉장히 경쟁력 있는 시대를 앞서가는 의료의 수준을 보여주고 있었는데 지난 2월서부터 여러 가지 이유로 인해서 의료 의정 사태가 발생해서 정상적으로 돌아가지 못하고 있는 모습이 너무 안타깝습니다. 조속히 빠른 시일 내에 올바른 방향으로 바로 잡아지기를 바랍니다. 오늘 스노메드시티 한국 주도 심포지움에 참석하신 여러분들을 진심으로 환영합니다. 2024년 스노메드시티 비즈니스 미팅과 엑스포를 우리나라에서 개최하게 된 것을 다시 한번 축하드리고 개인적으로 기쁘게 생각합니다. 오늘날 보건의료 분야에서 데이터 기반의 의료 시스템 및 이에 대한 표준화의 중요성은 점점 더 커져가고 있습니다. 전 세계 80여 개국에서 활발히 사용되고 있는 SNOMED-CT, Systemized Nomenclature of Medicine Clinical Terms는 효율적인 데이터 관리와 분석 및 용어 표준화를 가능하게 하는 아주 중요한 도구입니다. 이번 비즈니스 미팅과 엑스포에서는 전 세계의 정책 책임자, 의료 IT 전문가, 연구자들이 한자리에 모여 스노메드시티의 구현과 연구에 대해 논의하는 중요한 기회가 될 것입니다. 이러한 기회는 앞으로의 의료진 간의 원활한 소통을 돕고 의료 환경을 개선하여 궁극적으로는 진료의 질을 높여갈 것으로 기대가 됩니다. 대한의학회는 의학 발전과 국민의 건강 증진을 위해 다양한 학술 활동을 지원하고 있으며 이를 통해 지속 가능한 의료 환경을 만들기 위해 노력하고 있습니다. 이번 심포지움이 그런 노력의 일환으로 스노메드 시티를 통해 데이터 기반의 의료 시스템을 정착 가능하게 하고 나아가서는 환자에게 좋은 결과를 가져올 수 있는 소중한 기회가 되기를 기대해 봅니다. 끝으로 오늘 이 행사를 위해 수고해 주신 모든 관계자분들께 감사의 말씀을 드리며 오늘의 심포지움이 서로의 지식을 나누고 협력을 통해 새로운 가능성을 모색하는 좋은 기회가 되기를 바랍니다. 감사합니다.
네, 회장님 감사드립니다. 네, 다음으로는 대한병원협회 이성규 회장님을 모시고 축사를 듣도록 하겠습니다. 회장님 부탁드립니다.
예, 안녕하십니까. 대한병원협회 회장 이성규입니다. 스노메드 시티 연례회의 기간 중에 열리는 한국 주도의 심포지움 개최를 진심으로 축하드립니다. 행사를 준비하신 한국보건의료정보원의 연민섭 원장님을 비롯한 관계자 여러분의 노고에도 감사드립니다. 이번 심포지움은 전 세계 전문가들에게 국내 보건의료 정보 표준화 정책을 소개하고 한국 주도로 스노메드 시티 활성화를 위한 맞춤형 별도 세션을 마련했다는 데 큰 의미가 있다고 생각합니다. 특히 보건의료 선도국인 미국, 네덜란드, 영국과 아르헨티나 등의 관련 정책 및 의료기관에서의 활용 사례는 우리에게 많은 교훈을 줄 것입니다. 또한 스노메드 시티가 어떻게 데이터 기반 의료 시스템을 지원하고 다양한 글로벌 구현 업체로부터 환자 결과를 개선하는지에 대한 다양한 의견도 기대됩니다. 이번 심포지엄이 정부의 의료기관 모두에게 환자 안전과 의료 서비스 질 향상 그리고 효율적인 임상에서의 의료 정보 활용 방향성을 마련하는 데 소중한 시간이 되시길 바랍니다. 다시 한번 스노메드시티 한국 주도의 심포지움 개최를 축하드리며 참석해 주신 모든 분들의 건강과 행운을 기원합니다. 감사합니다.
네, 회장님 감사합니다. 요즘 너무 바쁘신 두 분인데 이렇게 저희 심포지엄에서 축사를 해주셔서 너무너무 감사드립니다. 네, 그러면 이제부터 본격적으로 저희가 준비한 발표를 진행을 하도록 하겠습니다. 네, 첫 번째 세션은 정책 부문입니다. 정책 부문에서 처음으로 발표를 해주실 분은 대한민국의 보건복지부 심은혜 과장님이십니다. 심은혜 과장님은 보건복지부에서 데이터지능과 과장님으로 계시고요. 한국에서 데이터 표준의 업무를 담당하고 계시고 저희한테 너무나 든든한 백이십니다. 오늘 발표해 주실 내용은 Health IT Policy and Initiatives of Republic of Korea라는 주제로 발표를 해 주시도록 하겠습니다. 큰 박수 부탁드립니다.
예, 반갑습니다. 안녕하십니까. 저는 보건복지부 보건의료 데이터진흥과장 심은혜입니다. 의미 있는 자리를 만들어주신 오늘 행사에 도와주신 모든 분들께 감사드립니다. 특별히 스노메드시티 인터내셔널의 각국의 전문가분들, 또 국내의 보건의료 데이터 정책에 많은 관심을 가지고 늘 응원해 주시고 또 협조해 주시고 또 이끌어 주시는 많은 전문가분들, 오늘 함께 할 수 있는 굉장히 의미 있는 자리인 것 같습니다. 저는 오늘 대한민국 정부의 한국의 보건의료 데이터의 상호 운용성과 관련된 정책을 소개하고 관련 현황을 말씀드리고자 합니다. PPT를 제가 넘기는 건가요? 죄송합니다. 예. 예, 제가 오늘 말씀드릴 부분은요, 우선, 저희 표준화 정책과 관련된 배경, 그리고 또 현황과 주요 내용, 그리고 이제 앞으로의 계율을, 방향성을 좀 간단히 말씀드리고자 합니다. 먼저 배경과 목적입니다. 예, 보건복지부는 국민의 건강을 증진을 최고의 목표로 생각합니다. 그러려고 하면요, 의료의 질, 그리고 접근성, 그리고 효율성이 여러 가지로 준비가 되어야 합니다. 보건의료 데이터라는 것이 각각의 이런 정책의 중요한 부분들을 훨씬 더 개선하고 또 바람직한 방향으로 이끌 수 있다는 거에 가치를 두고 있습니다. 데이터 활용에 있어서 외부의 정책 환경 변화를 먼저 간략히 말씀드리겠습니다. 전 세계적으로도 인구 고령화와 또 전 세계적인 팬데믹을 오랫동안 겪어왔습니다. 그러면서 대면보다는 비대면 기술을 통해서 많은 기술의 진보가 있었던 것도 사실입니다. 한국은 많은 ICT 분야에서의 인프라가 좋습니다. 그리고 의료기관에서 전자의무기록이라고 하는 정보화를 일찍부터 이루었습니다. 이것이 기반이 되어서 본격적인 데이터 표준, 데이터 활용에 대한 기반이 갖추어진 측면이 있습니다. 예, 두 번째는 이제 의료 이용에 있어서도 이 의료 이용하는 가운데 보시는 저 환자를 중심으로 의료 진료를 이동할 때 또 회송할 때 불편하고 복잡한 절차를 기술을 통해서 또 제도를 통해서 이전에는 서로 그 상호 운용성이 허락하지 않았던 그런 많은 기반들이 좀 바뀌어 가고 있습니다. 무엇보다도 환자의 의료 기록은 개인정보입니다. 그래서 이런 개인정보를 보호하는 측면이 한쪽에 있고 또 개인정보를 의료 이용에 활용하는 측면이 있는데 데이터 기반의 정책을 통해서 보호에 충실하면서도 이제 활용에 대한 계기를 점차 늘리고 있는 추세입니다. 상호 운영성에 대해서는 여러분들 잘 아시는 것처럼 서로 다른 정보 시스템이라 하더라도 동일한 의미와 이런 의 데이터를 서로 교환함으로써 상호 이해를 높이고 편의를 증진하는 일련의 개념을 의미할 것입니다. 여러 가지의 이제 단계가 있겠지만 첫 번째 원칙과 체계를 수립해서 우선 데이터 표준을 기반을 닦는 작업을 하고요. 그거를 가능하게 할 기술이 있어야 될 것입니다. 그래서 핵심 기술 기반을 확보하고 이를 통해서 데이터 표준을 통해서 의료기관 간의 진료 편의를 높이고 또 다기관을 통해서 하는 연구의 효율을 높이는 그런 작업을 추진하고자 합니다. 한국은 전국민 건강보험 제도를 통해서 기본적인 의료 정책이 추진되고 있는 나라입니다. 이를 기반으로 의료 전달 체계가 수립이 되고 모든 국민들의 의료 접근성을 높여가는 정책을 하고 있습니다. 데이터의 표준을 통해서 이런 상호 운용성이 높아지면 정부 차원에서는 각종 데이터를 활용할 수 있는 사업에 활용되어서 이것이 활성화될 수 있고 기본적으로 환자에게 그 가족의 편의가 갈 수 있다고 생각합니다. 의료인 입장에서도요, 바쁜 의료 현장에서 복잡하게 환자 기록을 확인하지 않아도 직시성 있게 활용할 수 있고 공유할 수 있고 불필요한 검사는 지양할 수 있는 장점도 있을 것입니다. 무엇보다도 환자 입장에서 이 증상의 차이로 전원이 필요할 때 건강정보를 공유할 수 있고 응급실과 같은 위급한 상황에서도 진료 기록을 효율적으로 공유할 수 있고 궁극적으로는 이런 만성질환과 고령화 사회에서 개인 주도적인 건강관리가 가능할 수 있다라는 장점이 있다고 생각합니다. 예, 두 번째는 의료 데이터의 상호 운용성 관련된 경과를 좀 간략히 말씀을 드리겠습니다. 제가 모두에 말씀을 드렸지만 한국은 전자의무 기록이라고 하는 의료기관 내의 표준, 기관 내의 정보화는 굉장히 빠르게 갖춘 편입니다. 하지만 상호 소통하는, 상호 운용성을 높이는 작업은 비교적 최근의 일입니다. 보건복지부는 이러한 체계 내에서 어떻게 의미 있는 표준화 작업을 할 수 있을까에 대한 고민을 하였고, 우리는 민간 합동 보건의료 데이터 표준화 추진위원회를 구성해서 민관이 협력해서 현장의 의견을 기반을 수렴하면서도 글로벌 표준에 맞출 수 있는 표준을 고민하였습니다. 보시는 것처럼 보건복지부 아래에 보건의료 데이터 표준위원회를 두고 분과별로 핵심 교류에 대한 워킹그룹, 차세대 기술과 관련된 워킹그룹, 또 거버넌스와 관련된 워킹그룹을 두고 각자의 역할을 수행하였습니다. 예, 그래서 궁극적으로 KR-CDI와 KR-코어라는 것을 도출해내고 관련 도시를 개정해 가면서 확산하는 작업들을 하고 있습니다. 보시는 것처럼 한국의 핵심 교류 데이터 KR-CDI는 분류와 항목값, 항목에 대한 것들을 핵심 데이터를 정의하고 관련되는 세 개의 카테고리에 대해서 표준 분류와 표준 항목 그리고 표준 용어 세트의 집합을 정의하였습니다. 이렇게 필수 핵심이 되는 교류 데이터를 정의하면 전송할 수 있는 표준도 필요한데요. 이전에 그 HL7V2라든가 CDA의 한계를 넘어서 국제표준의 HL7 바이어 기반으로 핵심 교류 데이터를 교환할 때 준수해야 하는 데이터 형식, 제약 조건 등이 정의된 상세 규격을 마련한 바 있습니다. 예, 그 개발 경과를 조금 더 보시면 전체적으로는 저희 표준화위원회의 워킹 그룹의 전문가를 통해서 의사 결정을 하였고 또 관련된 초안을 만들었습니다. 그래서 이제 미국과 호주와 같은 해외의 사례들 또 국내 현황에 맞는 국내에서 많이 쓰이는 부분들을 고려해서 KR-CDI의 버전 1을 개발을 완료하였고 출판하게 되었습니다. KR-CDI와 KR-코어의 세부 내용도 보시면요. 전체 대분류인 14개의 클래스와 또 77개의 엘리멘트까지 이제 초본이 개발이 되어 있고 이를 전송 표준에 쓸 수 있는 KR-코어로서 프로파일링을 하고 관련된 IG를 출판하는 작업까지 이르게 되었습니다. 예. 향후 계획을 말씀드리겠습니다. 표준은 기술에 따라서 정책에 따라서 상황에 따라서 변할 수 있는 것이라고 생각합니다. 현장에서 얼마나 잘 쓰이고 이것이 좋은 의미를 수단하는 실현이 될 수 있는지는 늘 현장의 의견이 반영되고 또 시적절해야 한다고 생각합니다. 저희는 KR-CD와의 KR-코어에 기반해서 이것을 매년 고도화하는 작업들을 지속할 것입니다. 현장에서 쓸 수 있어야 하기 때문에 국내에서 쓰이는 것과 또 이런 국제적인 것 간의 간극도 점차적으로 줄여 나가도록 하겠습니다. 무엇보다도 확산을 위해서는 국가의 주요 사업들, 주요 정책의 표준을 활용해야 할 것입니다. 왼편 하단에 보시는 것처럼 저희는 의료 마이데이터로서 건강정보고속도로 사업을 하고 있고 또 진료정보 교류와 또 EMR 인증 또 주요한 국가의 데이터 사업들의 국가 표준을 적극적으로 활용할 것입니다. 임상 데이터뿐만이 아니라 요즘에는 운동이라든가 걸음이라든가 이런 생체의 데이터를 포함하는 개인 생성 보유 데이터인 PGHD와 관련된 것들도 활용에 대한 요구들이 꽤 많습니다. 그래서 관련된 표준 가이드라인을 만드는 일도 진행을 하고 있습니다. 무엇보다도 의료기관에서 의료 현장에서 잘 쓰일 수 있도록 하려면 표준으로 로컬의 용어들을 변환하는 그런 작업들이 필요한데요. AI 시대에 이 AI 기술을 활용해서 이 로컬의 용어들이 표준으로 쉽게 변환할 수 있는 그래서 의료 현장에서 쉽게 사용할 수 있는 그런 기술 개발도 추진해 나갈 것입니다. 마지막으로 드리고 싶은 말씀입니다. 데이터 표준의 정립이 의료 R&D의 연구, 또 의학의 연구, 또 정책, 또 사업에 있어서의 가장 기본이라고 생각합니다. 이것이 잘 쓰일 수 있는 기반을 최근에 이제 한국 정부는 마련하였고 이것을 고도화하고 발전시켜서 국민의 건강 증진에 도움이 될 수 있는 데이터 기반을 지속적으로 강화해 나가도록 하겠습니다. 앞으로 많은 관심과 협조를 부탁드립니다. 감사합니다.
네, 심은혜 과장님 감사합니다. 심은혜 과장님께서 한국의 데이터 표준화에 대한 정책을 발표해 주셨습니다. 네, 다음으로는 스티븐 포스낙의 미국의 정책에 대해서 발표를 부탁드리려고 하는데요. 아쉽게도 한국에 오시지 못하고 동영상으로 대신 보내주셨습니다. 스티븐 포스낙은 여러분들 잘 아시는 ONC라고 하는 오피스 오브 더 내셔널 코디네이팅 for 헬스 인포메이션 테크놀로지에서 데퓨티 내셔널 코디네이터를 맡고 계시고요. 오늘 발표 제목은 유나이티드 스테이츠 인터퍼러빌리티 폴리시라는 주제로 발표를 준비해 주셨습니다. 오늘 참석은 못했지만 이렇게 소중한 동영상을 보내주셨는데 잘 청취해 주시면 좋을 것 같고요. 혹시 아까 말씀드린 거와 같이 이제 통역기가 저희가 바깥에 준비되어 있어서 필요하신 분은 가져가시면 좋을 것 같습니다. 네.
Greetings, everyone. My name is Steve Posnack from the United States. I am happy to be here. It's a great opportunity. I'm sorry I couldn't be there with you in person. I wanted to say greetings from the past, literally because you're ahead of us time zone-wise, but also because I recorded this a few days ago. And as my wife would say, if I have to explain all this to you, then it's not funny. But it's, again, a pleasure to be with you today. And really want to dig into the subject that you asked me to talk about, which is the United States experiences with SNOMED CT, the topic du jour. And I will jump down right into it. Let me share my screen for you, and we'll get going. So I just wanted, again, to note that I'm from the United States government, the Department of Health and Human Services, and serve as now the Principal Deputy Assistant Secretary for Technology Policy. So you may say, hey, that name sounds new and unfamiliar to us. We were recently reorganized in July of 2024 to include new responsibilities, and those are the ones listed down there at the bottom. So we've taken on for the Department of Health and Human Services the HHS-wide role, so the Ministry of Health department-wide role for the Chief Technology Officer, the Chief Data Officer, and Chief Artificial Intelligence Officer. And so those are those components now that are part of our office. And as part of that reorganization, we got promoted a little bit from a overall business unit perspective. And so, you know, along our history, we've had a number of changes. In 2004 was when we were created. In 2009, there was a big law in the United States that created a lot of digital health related policy and investment. And then we had another one in 2016 that we called the 21st Century Cures Act. So those really serve as the basis and foundation on which we do a lot of the activities in which we're involved. Just to give you a sense, and I know this may be an eye chart depending on how far away you are from the screen, to give you a sense of the overall work that we do across the executive branch, the U.S. federal government. On the left side are all of the different HHS agencies in those pie charts that we interact with from a digital health perspective. And then on the right are all of the different agencies across the executive branch that touch digital health in some form or another. So that includes agencies that you may be familiar with, like the Department of Veterans Affairs or our Federal Trade Commission. I like to point out NASA, who I'm sure many of you are familiar with. Even astronauts need healthcare. And so there's work that we do with our colleagues across the federal government in service to our mission. So before I dive into the details, I wanted to level set just to give you a sense of the progress that we've made from a digital health adoption perspective, what we're focused on now, how we're approaching standard setting, and the work overall that we're engaged in. So in terms of our office's responsibilities, we have a number of core activities that we're involved in, and those will certainly expand now with some of those new responsibilities that we've taken on. So we administer what's called the ONC Health IT Certification Program. So we have a responsibility to ensure that electronic health records that are used in the United States as part of certain government programs include interoperability standards and other capabilities as we set forward in a regulatory process. And so that's something that we iterate on a every 2 or 3 year basis. And that's a way for us to raise the baseline from an interoperability perspective related to the nation's work. The second box here refers to our nationwide network oriented set of responsibilities. And so we refer to that as the Trusted Exchange Framework and Common Agreement. This is a network-to-network contract of sorts. It's a way to, again, level out all of the different policy and legal requirements that may exist across the United States and find a way to reach, as you guessed it, a common agreement on the best approach forward for a number of these requirements. This network and its governance processes launched at the end of 2023, and now we are working on expanding participation and the additional use cases that can be supported. Near and dear to this audience's heart is our work around health data standards. And I'm going to talk about the United States Core Data for Interoperability, USCDI, in just a minute. But that ranges from a coordination perspective all the way from HL7 to SNOMED to a few of the domestic related ones in the United States like RxNorm and LOINC, even though I know that's a bit international as well, to many others in order for us to achieve different interoperability-oriented use cases. And then lastly, I already touched on a bit with our standards work, but more broadly, we do a lot of public-private related work, either investment opportunities through grants and cooperative agreements, or other types of partnerships where we engage from a subject matter expertise perspective as well. So just wanted to give you a sense in terms of some of the other standards data information that I'm about to provide. As I mentioned, we had that HITECH Act, the federal law in 2009. And as a result of that, that helped to spur the adoption of electronic health records in hospitals and office-based physicians. So you can see from this chart, roughly close to about 100% of hospitals in the United States now have electronic health records. We're at about 80% for office-based physicians. And that's as a result of a lot of factors that I'm sure many of you have experienced as well. Generational changes, technology adoption, resources, and a variety of other factors that we're still trying to tackle to this day, including the broader care continuum. Some of these office-based physicians may not have been eligible for the incentives that were originally provided in 2009. But the big impact related to my talk today related to SNOMED is that the growth curve for all of this adoption and use goes along with, you guessed it, adoption and use of SNOMED in these electronic health record systems and the expectations to share information from an interoperability perspective. And so you can kind of use electronic health record adoption as a proxy for the ways in which both SNOMED is used generally, but across the care continuum, across the spectrum of different use cases that I'm going to dive into in just a bit. So one of the most concrete ways in which we affect change now from a technology policy perspective is our annual stewardship of what's called the United States Core Data for Interoperability. And so the core set of data that's used for patient care that can be exchanged across a variety of different use cases and settings, and really establishes a consistent baseline for the nation and for how to approach interoperable uses of data in the United States. And so anywhere we reference SNOMED CT, that really is us saying, this is the United States way to represent that data in a consistent approach. And so we look to expand this over time from a predictable, transparent, and collaborative process. We have this annual cycle, some of you may have participated in, where we're able to get input from the field, expand the number of data elements that are included, and also attribute those standards like SNOMED to those particular data elements. And I'm going to give you a sense of what that looks like. So this is USCDI version 4. It was adopted about a year or so ago. We've actually moved on to USCDI version 5, but I thought this was the easiest one to represent in terms of SNOMED CT. And you can see all these little gold stars that are spattered throughout the list there. Those are all data elements in the USCDI version 4 that we've attributed the use of SNOMED to. And so we're saying to the nation, if you're going to represent the specimen type from a laboratory perspective, you have to be using SNOMED CT. If you're going to, represent medication adherence, you have to be using SNOMED CT. And so this gives certainty and predictability to the standards process. And it's through your engagement in the work that you do that we're able to do this and reference so many data elements with available SNOMED CT, their value sets or other types of approaches. One other thing, given the international audience, that I would be remiss if I didn't mention is the collaborative work that we're involved in from the Global Digital Health Partnership. And I want to say thank you again, to SNOMED and all of its participants for making available a terminology set that can be used as part of the IPS. And so the International Patient Summary is, again, an approach now that various different governments and other international participants are pushing forward to support cross-border exchange. It's being adopted from a technological perspective in various different software products, and it's being supported in certain national health systems and other types of nationwide related infrastructure. And so, again, I just wanted to say thank you to all of you involved. This has been a part of a game-changing related initiative, and your support with SNOMED IPS terminologies has been essential to its growth and adoption going forward. So I was prompted a little bit to talk about our SNOMED CT experiences in the United States, and as I get to a point where I'm ready to pass along that wisdom and a little bit of conclusion, I did want to emphasize again, we are seeing a broad array of use cases that reference SNOMED CT. So that ranges from clinical documentation, all sorts of algorithms that are powering clinical decision support or other types of new AI and algorithmic related models and approaches, certainly used as part of research, public health reporting, which, as a result of the pandemic has certainly increased our awareness and focus on getting high quality data reported to public health. We do a lot of quality measurement as part of various government programs, and SNOMED CT plays a role in the specification and digitization and computability of all of those quality measures that are included. And equally, as we look at safety analyses, again, for reporting, other types of standardized data that can be used, and many, many, many more use cases that I could probably go through. The one thing that I would at least reflect back on in terms of our experiences is that, at least at this point, there's a lot of as-built infrastructure. Systems get purchased over various iterative time periods in terms of their technological implementation. And I would say as an industry as a whole, not that it's a bad thing, but we just cannot escape mapping and data normalization. And I think that's just the reality that we face. And so even when we include in certain requirements that SNOMED CT be used, it's really being formatted at the edge. And so the local data may not be formatted natively within, or using SNOMED CT. And so that's one of those issues that we talk about in terms of looking, can we improve data quality? Can we improve the use of these standards upstream in some of the use cases? And that's work ongoing across the United States. But we have this infrastructure that's built, we have these local implementations. And so a lot of the work that goes on is looking at various mappings and other types of normalization activities to get the data as fit for purpose as possible and, building them in over time. So the other thing that we deal with from a SNOMED CT experience is, I'm sure, and I think we have representation there from our National Library of Medicine. That's a collaborative relationship that we have within the United States government. There's other kind of collaboration going on across the U.S. with other SDOs. There's this LOINC plus SNOMED collaboration for the extension of SNOMED CT. And so that's another encouraging related development, I would say, in the standards community. But the thing that we have to keep in mind is that we have to maintain versions of SNOMED that connect to our US CDI. That iterates every year. SNOMED gets updated and medicine changes. And so you have all these different dimensions that you're trying to stitch together and keep, for lack of a better word, sane for everyone so that you can keep making progress, keep representing that data in a standardized way, and make sure that it's interoperable across the board. The last thing that I wanted to reference, and I'm sure this is different for all the global participants, is related to the increased impact of patient access. So we've had a number of efforts, I didn't include the statistics here in this presentation, to increase our ability as individuals, our ability as patients or caregivers to access health information electronically. And so when that happens, we get a lot of data, in our hands, some of which is standardized in SNOMED CT. And so we have this ongoing growth an adolescence, I would say, in our work to improve health literacy. And that's a combination of both digital literacy and health literacy, or digital health literacy. I think you often hear, or we often say, that SNOMED is clinician friendly in comparison to other terminologies or code systems that could be used. And, I think we're seeing a growing need to have something that's patient friendly as well. And that's not to say that, SNOMED isn't patient friendly, but I think there's additional work that we can do, especially given, the wide array of experiences that all of us have in terms of patients in our communities, and their ability to really understand the terminology and data that they're getting now electronic access to. And so that, I think, is an opportunity for all of us to continue to work together. So with that, again, very much appreciate the time to do a little digital address to you all. I hope this placed well in the rest of the agenda, and I look forward to crossing paths with all of you in 3D at other events and opportunities in the future. Thanks very much. If you need to get a hold of us or want to track us down on social media, there's some information for you there. You can check out our website at healthit.gov. And again, take care, everybody. I wish I was there. Have a great rest of the conference. Thanks.
네. 미국의 앞선 정책을 들을 수 있는 좋은 기회였던 것 같습니다. 네, 다음으로는 헤르코 쿠만을 모시고 네덜란드 인터로퍼빌리티 폴리시에 대한 발표를 듣도록 하겠습니다. 헤르코 쿠만스는 네덜란드 미니스트리 오브 헬스 웰페어 앤 스포츠, 아마 우리나라의 보건복지부와 비슷한 그런 기관이실 것 같고요. 여기서 디지털 헬스 폴리시 코디네이터를 맡고 계십니다. 큰 박수 부탁드립니다.
Here. First, can I get a round of applause for the translators, because our lingo is not that easy to understand and to translate, and they're doing an amazing job at that. So thank you for having me, and thank you for this opportunity to speak to you about our road to implementing SNOMED in the Netherlands. And I will try to be brief. I can talk about these topics and about the topics that are on this whole conference for maybe 2 days, so don't let me. And I will start with why I am here. Not why the Netherlands is here, but why I am here. And this is probably the main reason why I'm here. These are my 2 children. Emma of 13 and Simon, who is 9 years old. And they are, statistically speaking, the first generation that where at least half of them will become older than 100 years old in good health. So I found these on the internet. This was not done through AI, by the way. This was just a lucky shot. But imagine that there will be 90 years of health data. Oh, sorry. Where is the? Yes. 90 years of health data available about them. How can we leverage that so that they live healthy lives? So that is why I am here, to make it sure that their data is good. I travel around a lot for my work, and one of the sessions that I was in was by this man. This is Professor John Cohen, who is an IEEE fellow and was the IBM Internet of Things lead. And he had a presentation where he said, we are now at the crossroads. And the crossroads is either technology shapes society or society shapes technology. And we want the latter, I think. We want that society shapes technology. And for that, we use standards. Standards are the tool that makes us more human. They translate our values like autonomy and safety and security, all those societal values, they translate these into the requirements by which we then use technology in order to shape the society that we want. So that is the work of standards and people who work in standards. This man understood this. He understood that when you standardize, and when you standardize with language, you actually bring people together. So this is 650 years ago, something like that. So Korea was leading centuries before the rest of the world. And this is an inspiration for how we want to use language and to integrate our peoples. Now, I'm not sure if you were aware, but in Europe, we had an event a few years ago, which was called Brexit. And this group of people, this is the previous European Commission. The new one isn't settled yet, so they are almost out of the door, but the chair is still the same. They wanted to prevent that there would be another Brexit. And they said that in order to prevent that people are leaving our combined union, we need to ensure that countries are as integrated into the union as we can. It's not to lock them in, but to make it useful for them to be together and to work together. And the first priority that they had was health data. So now, 4 years after they started, there is a regulation, which is European law, which is a regulation in 27 countries, which is called the European Health Data Space, and it integrates our health data across 27 countries. Again, I think here Korea set the example, and we just follow. So this is a really big part of why are we doing all this work. Now, I work at the Ministry of Health, Welfare and Sport. The design of the Dutch healthcare system is very similar to the Korean one, so I won't go into detail about how the Netherlands is organized. But on the digital health part. So one of the things that we did in the past 5, 6, 7 years is we spent a lot of money trying to incentivize the healthcare professionals and the healthcare institutions to use, not to just digitize their processes or their data, but to do that in a structured way and to make that data available so it can be exchanged between healthcare providers. So these are the types of healthcare providers that have received funding, which is over €500 million, which is for us quite a lot of money. So this was then the carrot that we gave them. So it's a lot of money, and we spent them, and they had to follow the carrot and then hopefully become more interoperable. The first lesson that I want to give you from our experience is that carrots is not enough. You can spend a lot of money for this to happen, but standardization isn't just developing something that everyone can use. A standard is only a standard when everyone uses it. I mean, we can use electricity in many different power plugs, but it only works if your house only has one type of power plug, because it's that simple, maybe. So we also needed something else. And this is where government then is the only organization that has the power to do that, and that is to provide hard rules that everyone needs to follow. So on the one hand, you have enabled them to do it and to build their own capacity so that they can exchange data electronically and in a structured way and in a standardized way. And now you need to mandate that everyone follows those rules. So we have a law called the Electronic Data Exchange in Healthcare Law, which is government is not very good at thinking of good names. So there's different areas that we are focusing on to make that mandatory. And this then, the law, is the stick. So on the one hand, you have the carrot to lure them in, and the stick is then to make sure that they actually, the ones that aren't doing it by themselves, are incentivized to do it anyway. Something that is very particular to the Netherlands, but is very important to us, which is what makes it very difficult. The Netherlands doesn't have any public healthcare delivery. So we only have private hospitals and GPs and clinics and pharmacies, which means that there is no government procurement that we can use to incentivize or to make mandatory the exchange of standardized health data. We also do not have a national health information exchange infrastructure. That's due to privacy politics 12 years ago, and we're now recovering a bit from that by building it, but still we don't have it yet. That means that we cannot say you have to comply with these standards because you have to connect to our national infrastructure. That leaves only one lever that we can use in order to make this happen. And I think that is the best one, but it's also the extremely difficult, which is the quality of care. So we say in this law, if you don't exchange data in an electronic and standardized way, you are endangering your patients. You are not providing the right care. And we can do that in this law because what we mandate is based on the professional standards of quality that the professional groups develop. And we translate these into an interoperability need and a data exchange need. So both the content and the technical exchange part. And we mandate those two. So they are based on what the doctors and the nurses and the physicians themselves say. This is what we think of as the quality that we need to be able to deliver. So that's the way we mandate this. But it is the most difficult route, but I think it is also the most sustainable route because it's not that they have to because of the technology needs it to, or that they needed to get their money, but it is because it is their quality of care that demands it. So it's actually their own requirement. So we have a very similar core data set for interoperability as the US and many other countries, and also the one that we saw earlier of Korea. And I will skip this really fast. But one of the things that we've been doing is that you can have a core data set, but you also have to provide structure for all these different data elements. So one of the things that we've done is we've created a standard for healthcare information models, which are sort of, you can see them as Lego. So on the one hand, we have a terminology like SNOMED. Then we structure that in a building block that is the healthcare information model. And then you can stack those healthcare information models into a core data set for interoperability. But you can do that for many different... Ooh, microphone thinks I'm done already. You can do that for many different applications as well, not just for a core data set for interoperability. You can do that for patient summaries or for medication overview or for medical images, or for, I can go on with that list for a long time. The idea is we now have about more than 100 of these healthcare information models that are modeled by the professionals as well. So they are increasing the reuse of this data much more. Now onto our SNOMED approach. We call this the Mickey Mouse model for obvious reasons. So what we want to have is, or what we have is a reference terminology, which is SNOMED. We have IDMP for medication, medicinal products, and we have LOINC for lab results and other measurements. There are aggregation terminologies, and then we have national content. What we really want to go to is more, let's see, there's more clicks, that we integrate them into our national reference terminology, which is based on SNOMED, or based, it's SNOMED, translated into Dutch. This is actually what happened. So we wanted to do a lot of these things, but probably like due to many different reasons, we ended up with many different products that we use in different parts of the healthcare system. So now we try to bring it back to that model that we envisioned, and to get back to the get it all into the Mickey Mouse model, which is actually a lot of complex work, and we're not done by a long shot yet, but it's at least it's a shared vision that we want everyone to work on. This is a longer animation, so I'm going to be silent now. And what we really hope is that as a result of doing this with these international classifications and standards and terminologies, is that we can then use that to create our national extensions on top of that, because we have a very solid base of what's already internationally available, which makes it more applicable in our local situations. Now we've asked our National Competence Center, NICTIS, to provide us with guidance in how do we implement SNOMED in the Netherlands. We've been a charter member, so we've one of the founding members of SNOMED, so we've been working with SNOMED for the past 10 years. Our legislation, our stick, if you will, is very recent, so we haven't used the stick yet to implement SNOMED. And even if you want to use the stick, it has to be feasible for everyone to implement it. So we asked them to do a step-by-step implementation strategy to suggest that for us, and this is what the advice is, and it's currently in a consultation, so we are building our policy on top of this. Key in this is that we want to use SNOMED as a registration standard, not at somewhere at the end, but as the base where everyone uses it for their own EMR. This is to prevent that we have so many maps that it's going to be more difficult to manage all the maps than to actually apply the core terminology. And that we use SNOMED in a very staggered way. So it's not everything for everyone, but it is a targeted approach. And to start with, what everyone is using is a diagnosis and treatment, and to use that and then expand on top of that. So it's a step-by-step approach. And I think one of the biggest lessons here is that you need leadership in order to get this done with all the different organizations and stakeholders involved. So what we asked our healthcare sectors, our GPs, our hospitals, our pharmacies, our mental health, is to draw up plans of how they would implement SNOMED within their own sector. Again, there's no government healthcare delivery, so we have to do this bottom up. Of course, the government will provide the resources for that. And of course, we are promoting SNOMED everywhere that we can. So these are the 6 sectors that are now drawing up these plans how to use SNOMED. And you can see it's not just the very clinical side of it. So it's mental health, it's the general practitioners. And this wasn't mandated, so we didn't say you have to do this, but we asked them to take advantage of the resources that we provide before it becomes mandatory. We asked them who wants to be first in drawing up your plans. Again, this is how you start implementing it, is don't do everything for everyone at the same time, but start with what's the most logical, where the biggest value is for most of these organizations, and that is diagnosis and treatment. The second one is, again, you need leadership, but it's not, it must not be top down. You have to involve all the stakeholders. And that's what we do with what we call field teams, which are groups that go to hospitals, go to general practitioners, that actually help them assess what is needed to get their questions right. Most of the time they don't even know what they should ask for. So we try to make that more clear and to basically help them draft their plans. And the other one is that we can do that with the healthcare providers, but the vendors are a very big stakeholder in this too. So we engage with them too in order to make sure that they support their clients in this journey as well. So in summary, so we have a national collaboration, but it's per sector, but it is a national effort. And because we use these teams and we do this staggered implementation, we hope to get achievable annual goals so that it can be, it's actually doable for them and they can celebrate their success when they achieve their goals. It is not easy. Implementing this is not easy. It's not a technical thing. It's a change management thing. It's people have to let go of things that they've been working with for years. So they need to help each other too. So it's very much a community effort. And therefore, you need to provide the support through these teams. Again, it's a change management thing and with a shared goal. This is an old African saying, I think. You can't eat an elephant in one bite. You have to start somewhere, so take small bites. And that's how we try to approach this. So thank you very much.
네, 탑다운이 아니라 실제 실무에 있는 다양한 팀들과 코디네이션을 하는 좋은 리더십에 대해서 잘 발표를 들은 것 같습니다. 네, 그러면 저희 정책 세션을 이것으로 마치고요. 브레이크를 좀 가진 이후에 3시에 세션을 시작할 예정입니다. 잠깐 커피 드시고 한 5분 전에 좀 자리해 주시면 감사하겠습니다. 감사합니다. the time is 네, 지금부터 저희 두 번째 세션을 시작하도록 하겠습니다. 저희가 첫 번째 세션에서는 각국의 펄러시에 대해서 우리가 그 발표를 들어봤었는데요. 지금부터는 스노우메드 시티와 상호 운영성을 실제 병원에서 어떻게 적용하고 있는지에 대해서 해외 사례와 최신 기술 동향을 들어보도록 하겠습니다. 네, 먼저 첫 번째 발표자분을 모시도록 하겠습니다. 닥터 찰스 구트리지 박사님을 모시도록 할 거고요. 닥터 찰스는 Barts Health NHS Trust에서 Chief Information Officer로 근무하고 계십니다. 영국 병원에서의 상호 운영 시스템에 대한 구축 경험을 공유해 주셨다고 하셨습니다. 네, 큰 박수로 부탁드립니다.
안녕하세요. 오. So I am Charles Gutteridge, and I have some thank yous to give. So first, I'd like to thank Professor Parks, who, for reasons unknown to me, decided I was the one that should be invited to talk about local hospital deployment. I have to say I've stretched it a little bit because I think in England, we can't really any longer talk just about a hospital because we are very much a connected ecosystem. But one of my themes this afternoon is to talk about time, because I think you can see I'm now an older person, and I would say that my lifetime experience is going from a very, very simple electronic health record system when I was a student in the mid-1970s to a fairly developed system, but still an incomplete one, so, 50 years later. So this is a never-ending journey. It takes forever. And actually, as medicine has got more complex, the complexity of what we all face has become mind-bending, really. And I think each of the speakers in turn have talked about complexity, but it is a really, really important part of what we think about and do. And that you have to do different streams of work all at the same time. You can't just simply say, we're going off to implement SNOMED, because you have to have an EHR system. You have to have an infrastructure and so on. I've already been introduced to where I am, but just in case you're interested, Barts Health Trust is an academic health science centre in the east of London with 5 hospitals in it. And I want to start in a slightly different place, really to try and engage the Korean part of the audience here, which is to say, about 3 weeks ago, I went to the theatre in London to see a production of King Lear done by a Chung-uk group from Korea, your national Chung-uk company. And this was the stage that faced us before the production started. And I think it represents a sort of bleak view of how King Lear operated. And I don't know if you know the story of King Lear, but it's a very complicated story. And it's one that I suspect suits the Korean mind particularly well. Here are some of the actors in that production. And I think the thing that I want to try and get over is the question of how humans do semantic interoperability. So at the end of this production, which was about 3 hours and 15 minutes, my heart was pounding. There was an amazingly strong emotional feel in the theatre, driven by the content of the play, but also driven by this amazing group of players whose singing and acting was of extraordinary quality. And none of us had any difficulty in understanding what it was about. It was a feeling. And humans are fantastically good at that. And I think whatever we hear about AI and everything else, computers are sensationally bad at it. There's no reason why a computer should have emotions or feelings, but it's how we operate. Interestingly, the sort of concept behind this has got a code. It's not well defined. In fact, it has no relationships, no attributes, nothing. It's just Han. But again, I'm looking at the Korean population here and saying, Han has a specific meaning for you as a people of suffering, of grievance, of unhappiness, but where there's also a sort of glimmer of hope. And I want to just share with you a Han story from East London that goes back to about 1880, when a surgeon at the London hospital where I work, called Frederick Treves, came across a patient in a circus who had hideous deformities. And he wrote a book about that, and indeed other experiences at the hospital, called The Elephant Man. And you're probably aware of The Elephant Man, because it was made into a very famous film in the 1970s about the suffering of the Elephant Man. Frederick Treves himself, as a surgeon, did no further work in the field. He did a few operations. He actually operated on the King of England and became knighted because he operated on the King's appendix, but not because he looked after the Elephant Man. And then he was born in Dorset, which is a region of England. He got on his horse and he wrote a guidebook to Dorset, and that was the end of Frederick Treves. But, and here's one of my issues about time, 130 years later, we're virtually certain that the Elephant Man had Proteus syndrome, an amazingly rare condition. At any one time in the world, there's about 250 people with Proteus syndrome. It's what's called a mosaic syndrome. So only some of the cells in your body acquire the mutation. And it's a mutation of the ATK1 gene, which is an oncogene that controls cell growth. And if the mutation essentially disables it so that you get uncontrolled growth. And you won't be surprised to hear that it has a SNOMED concept attached to it. And it is fully defined. So now we're at a point where we can use these data, and I've highlighted two parts of the relationships and attributes. One is that this is a hereditary cancer predisposing syndrome because it's due to a mutation in an oncogene. And that, not surprisingly, it has associated morphology changes which are about neoplasm. And the challenge, I think, for you as developers and users of SNOMED in Korea is to inspire any kind of clinician, doctor, nurse, allied health profession, to understand something about this. Because I think it is often said that people don't need to understand SNOMED at all, they just need to use it and it'll all happen by magic. And I can tell you that my, probably 15 years now of working in SNOMED, with SNOMED, about SNOMED, none of my colleagues know or understand anything about SNOMED. I'm not the only doctor who knows something about it. There are a few others, but it is the word few that matters. And I think there is a fantastic challenge and opportunity for us all to stop pretending that you can do SNOMED without knowing anything about SNOMED. You have to teach, you have to learn, and you have to engage clinicians to understand why it's important to use. So I would say there are 4 crucial foundational requirements to build semantic interoperability ecosystems. The first is infrastructure, and I think we've heard quite a lot about infrastructure in Holland, infrastructure in Korea in the first talk. You have to have clinical systems. You just simply have to have EHRs. I think certainly in my own country, education and training, both in clinical informatics, but in SNOMED in particular, is absent from the medical curriculum. And I think increasingly, as people are beginning to explore the use of real-world data to do real-world trials, then there is engagement in most academics, or many academics, about how to use SNOMED properly for analytics. And this, I think, is really complicated from the point of view of the citizen and patient. So the citizen and patient now is expected, they may not really know, but they are expected to a large extent to manage their own health, to find their way through that complexity. I'm not saying that they need to understand SNOMED or to understand Proteus syndrome, but they all, as I'm sure happens in Korea, they use the internet to find out about themselves. And we as clinicians, supported by our management teams, provide them with a wide range of tools to help look after themselves. But many simply don't know what to do or how to use the infrastructure. And it is complicated because I'm sure it's the same, the organization of health in Korea is the same as it is in England. You might choose to go through the emergency care pathway. The way that works and the way you get a diagnosis is actually different to the one that if you go through outpatients, and different to the one you would experience going through primary care, and definitely different to the one you would get through social care. And yet they all link, and they are part of the interoperability system that we're all trying to develop and design. I just thought that I should alert you that I know something about your personal health record. I don't know what's in it because I can't read Korean. So there's an interoperability failure on my part immediately. But you clearly have much of the infrastructure and the systems to make all of this work beautifully. I think in England, something absolutely magical was designed about 25 years ago, called the NHS Spine. And that's essentially a national database that allows health and social care workers to access information through their systems, whatever that system is. And there are something like 20,000 different databases, electronic health records, clinical systems that can connect the spine and find the demographics of a patient, find some clinical information, both look at old prescriptions and message new prescriptions, what's called the electronic prescribing service, and then a system for core messaging across the NHS called MESH, which is the message exchange for social care and health. And that ecosystem of things residing nationally is used locally by me and all my colleagues and all my primary care colleagues to find patients and to populate the beginnings of an encounter in the hospital, in primary care and so on. Most of the source of truth in spine comes from primary care doctors, from GPs, but it's a magical thing. It holds the records of about 90 million people, of whom about 25 million are dead, and the rest are live patients. So we're already beginning to get a very big group of patients who are no longer with us, but potentially have data that might be useful for long-term population health purposes. The personal demographic service lists everybody with an NHS number. And that's very, very crucial. So if you have a rights to health service care in England, you have a number that identifies you. And that is the key identifier right across the system and allows us to message and interoperate, if you like, using that number. One of the key features is the electronic prescribing service. So I, as an individual patient, can go onto my PHR, the English version of the Korean thing, and request my GP to prescribe the rivaroxaban that I take. And I can do that with no contact with a GP whatsoever. We've agreed that I shall be a lifelong taker of that particular medication. And my next act, having requested for the prescription, is the GP approves it, signs it electronically, and that goes to a community pharmacy of my choice. And the underlying content of the message is SNOMED. That system works across the whole of England. And certainly speaking at a personal level as an individual patient, it's a thing of beauty and wonder, because I don't have to go to the doctor anymore. I can just press the buttons. The National Care Records Service lifts information from your primary care system and makes data about yourself available to yourself through the NHS app, as it's called. It used to be called the Summary Care Record Application, but it's now the NHS app. So I can see quite a lot of my own information, and any patient who's created an account and a login for the NHS app can do the same. And obviously that data can be shared with a physician, a surgeon, whoever, either through access of the National Care Record Service or by transmission of that information. And once again, the content is largely SNOMED implementations over time. There's other information as well, and there's inevitably free text and so on, but the core of the National Care Record is structured data and mostly SNOMED. The other bit of infrastructure that I think is crucial in all of this, and I think earlier we had a few members of DCSIO, but the NHS purchased or procured the DCSIO terminology server, and those are the content in the UK version of the terminology server. But you'll see SNOMED CT is there top and foremost as the tool that is used to populate people's records. But there are lots of other things, and like most countries, we have our own procedure terminology called OPCS4, which drives the billing process for surgical procedures. There's legacy coding of the Reed code system that was invented by Dr. Reed 40 years ago actually, and whose memorial lecture you'll hear if you come to the session on Friday morning. But there's other things there as well. I'm just going to try and talk a little bit further about a couple of these systems. First of all, GP to GP. So again, I think this is a thing of considerable wonder, partly because it was built in 2005 and is a system for exchange of a patient record from general practitioner to general practitioner. So if I move from my house in London and move somewhere else in the country and change GPs, I can go to my new GP and say, you need all the information that I've recorded over time in my record. Please use GP2GP to access that. So they make a request in their EHR system that makes a call to GP2GP, which is on the spine, which then makes a call to the old GP practice, which sends the GP record to GP2GP. Most of that messaging is, again, SNOMED encoded, and that took years of early work between sort of 2004 and 2010 to actually make it work properly, to make sure that deprecated codes, old codes, codes that made no sense, and so on, were eliminated from the system. But essentially, then my new GP uses the old GP's information, beautifully rendered, and mostly through the presence of SNOMED. At a more local level, in my bit of London, and actually this applies to the whole of London now, we have a health information exchange system, which is actually a derivation of an American product because we use Oracle's Millennium system, what you may know as Cerner. And that HIE has worked extraordinarily well in London. So all 9 million people who are residents of London will have their data available in this health information exchange. This is a view from my system in the hospital. And you can see that I can look at GP reports, and I can see their list of diagnoses, what are called events, examination, investigations, and so on. And I can look at that data. It's an immediate extract of whatever's held in the record at that moment in the GP. I can see all the vaccinations that have been administered to that patient. As an old hematologist, that was vital for the care of patients with blood cancers and so on. So knowing what patients have had in vaccination terms is of enormous value, and obviously was of enormous value during COVID and so on. And the source data there comes from many sources, because vaccinations is not only done in primary care. You can go to a local pharmacy to update your vaccinations. You may go to an ED department and get renewal of your tetanus if you have a cut or something like that. So those data are viewable at any time in different components of the system. So that's my hospital view, but the GP has an equivalent view. And I haven't shown here the sort of data that's available that comes from secondary care, but it's discharge summaries, it's emergency department discharge summaries, problem lists, medication lists, and so on. And also one can embed links to patients, for patients, using the process that I've put at the bottom. So this is a very full record of records available in most systems in London, and is, again, an enormous sort of step forward in terms of providing access to data about a patient immediately from many different sources. And I saw in the early slides that you have either an HIE system or you're developing HIE. And I do think this is one of the things that makes a new way of thinking about medicine. I'm now just going to interrupt myself and show you a video that I made with a colleague last week, and which is about a key component of what we do in the hospital in our pharmacy department. I'm in the medicines distribution unit at the Royal London Hospital in Whitechapel in East London. The unit holds all the medicines that we have, and it's distributed to our wards using a robot, which is in the background. But I'm here to talk to Aman Sidhu, who is our digital pharmacist. Aman, welcome, and it's so good to have you in conversation. Aman, tell me a little bit about what you do for us in the hospital.
Thank you, Charles. So I am the lead pharmacist for informatics. So all things digital systems come under my umbrella, whether that is a Cerner Oracle prescribing on the front end on the wards, or whether that's looking at the robots here down in the medicines distribution unit, also looking at the dispensing work. So I work with all of those. I work across the ICT, with the ICT team as well as the clinical teams. We help to optimize the systems to make them as clear and usable as possible and improve patient safety through that.
So you know how to program some of the care pathway development in an EHR, is that right?
That's exactly correct. So what the doctors will see on the front end, that is what we code in the back end. So it's nice and easy for them when they're looking for a medicine. They want it to look in a certain way, and we will build it so it's nice and user-friendly. And we build the whole pathway from the beginning of the patient's admission to their discharge, and including everything that we do down here to get that medicine to that patient.
And how do you know if you've made a mistake or not?
So we've actually got the opportunity to pull out reports. So you can pull reports to see what's been dispensed, for example. You can see what medicines have been prescribed. We also report through a system called Datex. So that there we're able to pull all the incidences. We then review them on a monthly basis with our governance team. And if there's anything that we can improve through the system, we do that together.
So I think that is a form of semantic interoperability. By that I mean that one system, it might be a human being, knows what's happening in another system.
Yeah.
This might be a computer. That's a rather different definition of semantic interoperability to perhaps the usual one. What does semantic interoperability mean for you?
So for me, it's about making sure that one system is able to talk to another system. So in this example, you talk about a human being to a computer, but it's about having computers talking to each other. So we have so many different systems within the hospital, and it would be fantastic if they were all able to communicate with each other. So for example, the dispensing unit that we use, which is called JAC now, called CMM, that talks to our Omnicell robot, and then the robot will shoot out the medication, but we don't have that final link where the robot talks to our prescribing tool on the wards at the moment, but that would be something that we'd definitely be very keen to do in the future.
And what role do you think SNOMED CT plays in semantic interoperability and in the usability of the systems we have?
Well, I think SNOMED is actually key to that whole process. So if you take it even from the beginning, from when a doctor is looking at prescribing it from the front end, we are building those codes in the back end. So for example, if you're looking at a patient's problem listing, I'm looking at the SNOMED code within the system, which is visible, and then you can pull that code and pull out every single patient that's potentially got that disease or condition. In terms of the robot is coded in that way as well. So we scan the barcodes in. We can then, if you have that barcode, you can then look at the website and you will see what that medicine is. So whatever barcode, you can always track it back to the drug, and you can see how many tablets or capsules are within that box, what companies produced it, and then you can also track what everybody's using in terms of what are their top 100 drugs in different hospitals.
And if you look into the future,
Yes.
and you think, I don't know, maybe a 3 to 5 year period, what will be different in 5 years' time?
Well, I hope that we'll have better interoperability. I hope that all of our systems will be talking to each other a lot clearer. I think that we have lots of fantastic super users at the moment, so making use of those systems, making sure that people are actually using all those systems to their fullest. We'll always have new developments in terms of AI, so using potentially AI for counselling. There's just no end to the opportunities, and I'm very excited for the future.
So am I. Thank you so much for talking to me.
Thank you, Charles.
Thank you.
So I've been reminded that I need to crack on and only have a few minutes left. So I'm just going to take you, I think,
through a couple more slides just to try and illustrate some of the work that we've done in our group of hospitals in East London. One thing that is absolutely crucial, I think, for effective use of all our systems as a data warehouse that works without fail. So this is an illustration of our data warehouse. I just want to illustrate two things. First, the bit in the middle with a blue bound that is bounded in blue is in the cloud. So we have a cloud-based data warehouse that takes information from a variety of systems on the top and feeds them out to other systems at the bottom. And in particular, in the right-hand corner, you'll see a little tub there called research, and that feeds data into our research database, which is now called the Barts Health Data Platform. It opened for use a couple of weeks ago, and it is basically a replica of what I've just shown you in the previous slide, but which is accessible by anybody with the right permissions for doing research. And we provide those permissions through a governance process and a data access committee. And it's a secure data environment where the key component is that the data never leaves this space unless there are very special reasons for doing so. And as we build more and more tools in the front end, we think this will be a thing that will suck people into using data and in particular using our SNOMED resources. I'll skip this one, but it was just a slide explaining a little bit more about how that secure data environment works. And then I want to give you a couple of examples of things that I think inspire individual clinicians. So we have a problem in East London. I have no idea whether you have the same problem in Seoul, but lots of the young people in East London, for kicks and for fun, inhale nitrous oxide, which they don't get from hospital services, they get from catering. So catering is used to pump up whipped cream and all sorts of things. And they inhale the nitrous oxide because it makes you laugh and it makes you feel funny. And it's really, really bad for you if you do that a lot. You get essentially a form of vitamin B12 deficiency. And the reason I show you this particular research project is that the whole research project was done by a medical student. And one of the things she did was to get our National Release Center to write or to model two codes for misuse of nitrous oxide and nitrous oxide causing combined myelopathy of the spinal cord. So those are now in the UK extension and used to track the population health problem of nitrous oxide abuse in the UK. And this, of course, inspired the medical student. They now know about SNOMED and they're spreading the love. And I think that's one way to do that. The other one I was just going to briefly talk about is this very generic question, which I think any of you who are a human being in this room will be interested in, which is, did I inherit a gene that's likely to result in me developing cancer later in life? And this generic question is one for databases, which is show me all the genes with a somatic mutation in samples that we've collected at biopsy of tumors and other things in patients. And those genes that have a reference term for cancer in the electronic health record, and then reference those to a pharma database to show me all the compounds known to modulate those genes. Now, every country in the world is working on the development of new drugs that inhibit the function of those genes. And this is a way of inspiring, again, a very wide group of clinicians and patients in understanding how you can use modern technology and modern ways of thinking about medicine to create good. And I think you can use the content of SNOMED. So the reason I showed you the elephant man, is that he has or had a hereditary cancer predisposing syndrome. And we can find those patients in our databases by using the relationships and attributes in Millennium. We're expanding that further by using genomic data and beginning to model that in SNOMED in a local extension and feeding that into a clinical decision support system for cancer treatment. We're using natural language processing of free text to identify patients with lung cancer very hopefully earlier in their pathway so that they have surgically resectable disease rather than end-stage disease. And we showed this at ASCO this year with a really interesting study of how you can do that. And then I'm just going to end on why SNOMED matters. It matters mainly because it's the thing that makes direct care effective and efficient. But it creates other resources, which I've listed there, that are very important. And if you want to succeed in this journey, I would say to do these 5 things. Make sure you know something about SNOMED and then share it with everybody you know. Support your teams, and this is a massive task. Herko talked about it, others talked about it, but getting doctors and nurses and other healthcare professionals to actually record a SNOMED code in an EHR is extremely hard and never-ending work. Develop a SNOMED CT analytics pipeline in the way I described. Make sure you have all the tools that SNOMED CT can support, and you're going to hear those from Anna and Alejandro in a moment. And then crucially, I think at the end, is you have to articulate clinical questions that both clinicians and patients want an answer to. And so I would commend to you that sort of generic question about cancer genetics and what that means for a population and what it means for the individual. And I'll stop there, and thank you very much.
네, 너무나 오랜 경험과 풍부한 내용들을 잘 전달해 주신 것 같습니다. 좀 저희가 시간이 지체되어서 좀 빨리 진행을 하도록 하겠습니다. 다음 스피커는 찰리 오테로이시고요. 하스피터 이탈리아노의 칩 인포메이션 오피서입니다. 네, 큰 박수로 모셔주시기 바랍니다. 너무 멀리서 오셨어요. 예.
A good beginning. So thank you very much. I will try to read a little bit quickly because we are with some delay. So thank you very much for the invitation. I came from Argentina. So this is that is work. I came from Argentina. We are at the very south of the South America, so it's almost the end of the world. And we work at a hospital that is not really a hospital. It's a network with 2 hospitals and many clinics. So the idea is to show how we use SNOMED CT. Our hospital quickly is a big hospital in the Buenos Aires, the capital of the country. So we are about almost 10,000 people working at the hospital with 2.5 million of visits from outpatient, 45,000 surgical procedures, and more than 40,000 hospital discharges every year. We develop our own electronic health record, our own health information system. My first disclaimer is I'm not SNOMED specialist, so I'm not the specialist in the SNOMED, but I'm a chief information officer of my hospital, and I have the responsibility to represent clinical data in our hospital in the way that the clinical data will be useful for the physicians that work in our hospital, for the nurse that work in our hospital, but also for the patient. So we try to represent, and even when I'm not a SNOMED specialist, I know what the SNOMED want to do. So this is one of the things that I will try to share with you today. So the other things that we need to think in my responsibility from my point of view is that all the things that SNOMED can do for us must be ready in the 15 minutes, 10 minutes that the nurse, the physicians is with the patient, because we need to have the opportunity to have code data, to have semantic interoperability between the contact with the patient, with the provider. So we need to have all the resources that the SNOMED has, ready for the understand the information that was into the system, that was creating into the system in order to get more useful information. So in one hub, we have the facility of free text that everybody knows, but it's not probably the way that the utility that we find in all the free text, probably today more than any years ago, but it still is not ready for us to be as useful as the structured text. And then we have a structured text as one of the strategies to have all the information code, but probably has not the power to represent what happened in the real life with this patient. So we need to find something in the middle that is interface vocabulary that play between the two words, the free text and the structured text. So the idea is anytime that a user, a provider, input a text into the system, some intelligent prompting interact with these users, but not in the way that asking what code is the best code for this clinical data, but with the idea which is the best concept that represents that you are trying to put into the system. In this way, if the system says that I think it's the best medical concept that represents what happened with your patient, we have two options. The text is recognized for the system and give two opportunities. It's a valid text, so have the detail that we need for understand what happened with these patients, and have the opportunity to ask to the provider if they know more detail about that, and we use SNOMED in this case to understand that we are thinking in the same term with the physician, but we have more options, more granularity, more detail, and maybe with more useful information to the system. And then also we can understand that the term maybe needs some mandatory detail. For example, if you are saying that this patient has pain, we need to know what kind of pain. And if you are thinking this patient or the physician or the nurse are trying to input in the system that that patient has a fracture, for example, or for example, and any other problem like diabetes, the mandatory level of detail is to ask the size, the localization of the pathology, or if the diabetes is type 1 or type 2. But we use also all the not valid terms to understand and to put a stop when the physicians, when the nurses are trying to put information that is not useful for the health information system. For example, if I understand that the physician, the nurse are trying to put some prescription, but they didn't say prescription of what, they say that we are recognizing that you are trying to put that you are giving a prescription to the patient, but please tell me prescription of what. So we use SNOMED in all these ways to understand what the physician, what the nurse are trying to put into the system, and what level of details SNOMED can help us to get in this interaction between the provider and the system. In another way, this work acts an input of problems, procedure, diagnosis, and auto-codification process, and then the incorporation of this term into the interface terminology that was referenced with the SNOMED CT and then was cross-mapping with any other classification like ICD-9, ICD-10, LOIC, NIC, NANDA, everyone you can use using the cross-mapping reference that SNOMED has, but also creating our own cross-mapping process for that kind of standards that SNOMED has not cross-mapping, or maybe some national issues in the system. And then if you're thinking in the structure of the language, you have the natural language at the beginning, the interface terminologies in the middle, the reference as SNOMED CT, and the output classifications in that way. So implement this kind of terminology services allow us to give a system that works not only for our hospital Italiano, but also for almost 100 other hospitals in the region, mainly in Argentina, Chile, Uruguay, El Salvador. It's intuitive for users because, again, they are not thinking about what code is the best code. They are thinking what term is the best term to represent what they're trying to say, and focus on the best level of detail. We have a policy in our hospital that we say that we are looking for the best granularity, the best level of detail to represent what happens, as SNOMED helps us in this process. And also we can integrate specific local extensions and supporting all the interoperability process that we have for the mandatory reports that the nationals ask for us. Again, we are using SNOMED as a strategy to represent all the information that we have in our health information system, and with the idea to have more real information about our patients. The system works in a very easy way with code, diagnosis, problems, procedures, medication, clinical orders, and every clinical finding that you want to say in the semi-structured way that you see in this screen. The users input the problem and the system offers some, in this case, mandatory refination, mandatory granularity. Then you have also some other level of detail when you have not valid terms, when you have a valid term, but the level of granularity is optional, and when you have also some two problems or two clinical terms into the same input, and you need to separate these two clinics into different problems for the system to understand what happened. So then we are here talking about interoperability, and I will try to show how we use SNOMED to interoperate between our system, but with other systems also. Use SNOMED to interoperate, increase our number of investigations, our number of research, also increase the capacity to perform management analysis, increase the production of scientific works, and also freeing health professionals to task the coding, so they are only interact with the system to represent what clinical terms they are trying to put. But the other big problem is that probably the problem list is not the best way to recover to research all the information that we need. So we are in a new step level that is to use natural language processing techniques to understand what happens when we have free text and not semi-structured text. So we use also this strategy to improve the quality of the clinical notes. If you see, you can see some terms in red, some terms in green. The term in red are clinical terms that was originally written as an abbreviation for the physician, for the nurse, and you have the chance to see that it's because they have more than one significance into the Spanish language. So they can put what term they prefer to be replaced, and the system replaces this abbreviation for an extended term that is easy to read and is the mandatory quality measure that, for example, Joint Commission asks to us to maintain into the clinical notes. When you see that the clinical term has only one exception, only one significance in the Spanish language, you see in green, and also you have the opportunity to replace into the 1 second. All the clinical terms that the system finds goes to the problem list, so we don't need now to put problem by problem into the problem list. We use the natural language processor techniques in order to code with SNOMED CT all the clinical terms that we find. We also recognize that abbreviation is not only a shortcut for write but it's also a shortcut for read. So we are not maintaining the valid abbreviation in order you have the extend term and also the abbreviation when you want to read. In that case, for example, arterial hypertension, that is HTA in Spanish, will replace for the clinical terms, but now we are going to put also the abbreviation to the shortcut in the reading. The other useful for the we use SNOMED in the natural language processing techniques is when we have some text that it was not processed. It's our legacy free text that we have in our system, and we use Argot. That is also a tool that is available for the other hospital that work with us in the way that they can put the free text into the system, and the system identify the clinical terms and could be coded with the SNOMED CT and also with cross-mapping to ICD-10, and also we have some mapping now working with ICD-11. You have all the clinical terms identified in the free text and the code in the same process. This is for some institutions that don't have this integrated into the electronic health record, and some have legacy in free text that need to code. But the new one is use some chats like LLM, large language model, in the way that now you are talking with the electronic health record and asking what happened with the patient. The difference between the large language model is a conversational agent that you are all the possibilities to ask, but it's still expensive in our country. So probably we are using more the natural language processing techniques because the cost of you are trying to work with Tana, that is called our chat, that is a multi-agent chat for in the research process, because as I'll tell you, it's still expensive. Tana is the way that the lunfardo, that is the language of the tango, called from the Italian woman, recording that we are the Italian hospital and Tana are the Italian woman in that language. And also you can ask whatever you want and the system responds with the information of this electronic health record of this patient in all the settings that we have contact. Today, early they say that we need to be prepared to 100 clinical histories. So we are now working hard to understand 20 years of clinical history, and it's really, really hard. So that this is a solution to find information in a proper way. The other thing is to implement clinical decision support. This is a drug-to-drug or drug-against-drug contraindication. And in this case, you have 3 opportunities to go to the green, that is okay, it's suspend one of the drugs, go with care, and not to add ciprofloxacin in this case. In the way that they are going to go, we know that if the physician decide to work with ciprofloxacin, we need to control some with other procedures. For example, with the asking for an hemogram, for monitoring neurological symptoms, or for monitoring ictus. So we know this because we have all code by the SNOMED CT, but also the evidence and the clinical guidelines are coded with the SNOMED CT. So when you have the match between the interaction between drugs and the probably the monitoring tasks that you need to perform if that drugs have any interaction, match with the interoperability semantic strategic and show you what you do in that case. This is possible about that. We have code all the process in the generation of the alert, and then we can also go in that way. And also we can show the information in a proper way using the colors, the risk, and the information, because we know that physicians mainly don't want to read too much. So they need to see how the important things are related with this information. And we order all the information that we have about the drugs using the mapping to SNOMED CT. And this is some of the tractor that we work. The other thing that we use, our physician lost, for example, up today, and up to date was mapped with the SNOMED CT. So we use the strategy of info buttons, and every time that we use the health level 7 technique of info button, every time that we have a problem list that has an information unit in up to date, we put the info button directly to that, that list of problems. And then when you go to the info button, they have directly to the information related because, again, we interoperate semantic interoperability between up to date and between our electronic health record. But this is also important, for example, for our electronic prescription law in Argentina. We have a national, or we are creating a national drug dictionary based on a SNOMED CT. So we need to have all the structure in the prescription represent in a SNOMED CT, but also the diagnosis in the way that we can send. Remember that Argentina is a federal country, so we have many health systems depend on the patient's lives, and we are a reference center into the country, so we have patients for all the states into the country, and we need to interoperate with several prescription systems depend on the provider of this patient work. So we use the dictionary of SNOMED CT, the Nation Drug Dictionary in that way. We have also used SNOMED CT to perform our chronic disease programs. In that case, we use the subsets that we create about what problem the patient has. Probably this is the use most common of SNOMED CT, what drugs they're using, what complementary study are they taking, and create the follow-up of this patient and can have some intervention about the chronic disease management. But also, it's important, Dr. Park mentioned yesterday, that it's important not only to code the clinical information that we have, but also every time that you create, for example, an educational resource, code this educational resource also with a SNOMED CT. Index will be probably the correct term in that case. These resources, these information resources, these receipts, for example, or related news with the SNOMED CT, and then you have the chance when you have a patient with some problem in the problem list and you have information units, information resources with the same code, only send this information to the personal health record of this patient, and you have a good information education process implement using a SNOMED CT after interoperability mapping. Then we have also the same strategy for medical education. We code, we index the medical information, the high evidence medical education process, and we show, we mix the patient data, the physician data, and the medical evidence between the system that used to give information about how to be updated with all the information using, again, SNOMED CT as an interoperability process. As I'll tell you, we provide with more than 100 other healthcare providers in Argentina, Chile, Uruguay, El Salvador, and maybe Brazil, if Brazil decides to go or not, even the same topic, but we are prepared to go also in Portuguese. So thank you very much.
네, 이렇게 그 남미 지역에서 엄청나게 이렇게 많은 일을 하시고 이렇게 저희도 많이 좀 배워야 될 것 같은 생각이 들었습니다. 이것으로 저희 그 임플리멘테이션 내용은 마치고요. 다음으로 테크놀로지 세션을 넘어가도록 하겠습니다. 테크놀로지 세션에 이제 세 분의 연자를 모셨는데요. 첫 번째 연자는 디에고 까민거 이시고요. HL7에서 데퓨티 치프 스탠다드 임플리멘테이션 오피서를 맡고 계시고요. 오늘 발표해 주실 내용은 글로벌 트렌드 on fire adoption에 대한 발표를 부탁드리도록 하겠습니다. 박수 부탁드립니다.
You want me to hold it? Hold it while you are ranking. Okay. Okay. Thank you very much for inviting me. And what I will go through is the Fire Toolbox. I only have 20 minutes and 100 slides. So I will go, I'm begging your pardon to the translator. So I'm ashamed of my English after Dr. Gutteridge, but I will do my best. These are my previous activities. So my idea here is to show you what Fire can do, and you will think that what is the relationship, but this is what will hold your SNOMED code inside. So whatever you put inside will travel inside one of our structures. So let's go to see Fire and IGs, implementation guides, Smart on Fire questionnaires, CDS hooks, bulk data access, and CQL. So it's not just one standard, but a standard family with several technologies. First, the Fire core spec. That's the URL. The current version is release 5. Most of the implementations you will see around the world are based on Fire release 4. Our industry is slow, and we try to use whatever we have in our hand when we start the project. We don't need to use the last version of the scope of the spec. Fire defines an API platform, and we use HTTP for transport. We use OAuth for security. We prefer to use JSON for syntax. We define Fire resources and data types, and we use the methods defined by HTTP, and we use our terminology. And when the things get serious, we use SNOMED CT. So Fire is the web for healthcare, and the RESTful APIs explain how 99% of the web and cloud services work today. Fire itself is not enough. So you need to profile Fire. You heard in our first presentation today that they were creating core IGs for Korea or for the Netherlands. So it's how we use Fire for our own specific purpose. Which resources we use. How do we exchange them? Which version of Fire we are using? What are the search parameters we allow for our searches in our servers? Which specific operations we created? How do we version our resources? Which are the mandatory and unsupported elements? Which terminology we use for the coded elements? This is where SNOMED CT enters the arena. And which elements are must support. We provide the tools and the processes to create profiles to adapt Fire for each realm, domain, use case, and project. These tools are FSH, which is a language, a standard language to create profiles, the IG publisher that will transform these files and profiles into an implementation guide, and the Fire Foundry, where you can find examples and reference implementations for your profiles. Why do we need implementation guides? Because it's how we represent the Fire resources to be used to solve a particular problem. Think about it as what the orchestra has to perform, the different parts that each party needs to abide to. The framework and guidance, use case and examples, which Fire artifacts, the conformance language, and very important, computable capability statements. So we can put our artifacts in a server, and the server will tell us if they are okay or not. An example is how to go from US CDI. US CDI or Korean CDI defines a set of the Netherlands, defines a set of data that the state thinks it's appropriate to exchange between the healthcare providers, and the Fire implementation guide is how this definition from the state is implemented in each country in real life, in the field. The CDI is generic, conceptual. The Fire implementation is what the bytes that are being processed. And why we do profiling? Because Fire is the API platform, but in order to know specifically for our own case what to expect, where and how to get it, we need profiles. That's an example you are welcome to explore on your own later. How Fire patient compares to Korean core or to US core. How extensions are created, terminology restrictions, cardinality on the elements, and behavior. The first technology we will see after profiles and FHIR itself is Smart on FHIR. I created one slide where you can see in one slide what it is about. Then we can go about defining or describing it. But if you remember this slide for each technology, at least you will know what it is used for. Smart on FHIR, in one sentence, secure launching and data exchange of patient and clinician-oriented apps with EHRs. That's the spec, and if you go to see an example, we don't have time today, but you can do it. So we have an embedded shared user interface. We want to show information in a different way. We have already an EHR, and we know the information stored in that EHR, but we want to show it in a different way that the clinician prefers. So we will embed our mini application inside of the EHR or the portal for the patient. Which are the problems with this? How can we authenticate? How do we substitute an application once we don't want to use it anymore? How do we do visual integration with the EHR? And how do we create one API for each EHR to extract data? Those are problems, and if you remember the Dante's Inferno, the inner circle is for programmers using different APIs for the same goal. So what do we need? Only one API. And remember, that's what FHIR is about, defines standardized APIs. One way of registering apps in the EHR, one way of launching apps, a framework for authorization and authentication, a way of providing context, and a way of exchanging clinical data. It doesn't matter which EHR or what your mini app does, this spec allows to connect and launch any application. This is the spec. You don't need to read now. And I wanted to share with you some Smart on FHIR real-life examples, courtesy of Axis Boxwala, a friend of ours. And this is not the EHR, this is the app inside of the EHR, helping the clinician, in this case, to know how many milligrams equivalents has been given to the patient so far and what will happen if they add one more, or a behavioral health smart app showing only the data relevant to behavioral health, or an hypertension smart app only showing the evolution of the hypertension of the patient, and finally a pre-diabetes risk assessment, combining a FHIR questionnaire with data from the EHR, inside the EHR. So these are the things, the kind of things you can do when using Smart on FHIR. Next, CDS hooks. What is it? Standard FHIR API for asking for clinical decision support knowledge and receiving answers. That's the spec, and you can follow an example. So in this case, we have an independent CDS service, and we want to provide any EHR with a service, given context about the patient and patient clinical data, apply knowledge, and recommend an action course. Remember, we don't care which CDS service you are providing. Anything. We create the infrastructure so you can call the service and get your answers. So the problem is that there could be a different API for each CDS service and a different API to access data for each EHR. And the solution is the spec. So we created a way to discover and register services, a framework for authorization, a way to describe the context, a way to exchange clinical patient data, a way to call the services, and a way to return the recommendations. And you can see there the diagram. The system will detect that the clinician is doing a specific job, like creating a new order or discharging the patient. We'll see which clinical decision support services will apply to this specific hook, because that's the name. We'll create the bundle of information to send to the clinical decision support service, and we'll get back the answers. Everything here will be coded by SNOMED, because if it's not coded, nobody will understand what the data is or the context is. And finally, the clinical decision support service will return through a card the recommendations. And the cards can be a mandatory action or a suggestion. And the clinician can even send feedback about, and I think Charly showed you, that they can send feedback about the result, the final result, if they accept it or not, the clinical decision support recommendation. It doesn't matter how the service implement knowledge or algorithms. Can be artificial intelligence, can be a simple algorithm, whatever you can, it's all right. We need to use the API to connect to any service and allow us to leverage it. This is the spec. And this is an example, very similar to what Charly showed you. So this is a CDS hook service that externalized from EHR complex and rapidly evolving genomic knowledge. So we send this, the current patient information and a pointer to a server that will understand phylogenomic, and applying these phylogenomic operations will give you back recommendations for this patient. In this case, is interactions with a specific drug. Next one, bulk FHIR. In bulk FHIR is a standard FHIR API for big data. Instead of getting one patient at a time, a very small quantity of resources, here you are getting hundreds of thousands of records at a time. Because the internet will not allow you to wait for 1 hour for a result if you want 100 million records, for instance. So in this case, we have population health, and we want to analyze data from a big set of patients. Why? Because we want to do research or apply discovery algorithms or calculate quality measures or epidemiological measures, and also maybe for initial load of your servers. So I can ask for the data and then process it. We have an extractor and an EHR data server. So in this case, some examples: recover vitals and demographics and labs for all patients with diabetes in the last 2 years, recover all procedures for patients covered by this network in the last 3 months, recover all medication, clinical notes, and demographic data for all COVID patients. How can we guarantee security? How can we do asynchronous processing? Which will be the efficient format for this exchange? Do we have one API for each EHR? And do we want a different format for each extraction? This is something we are being fighting with public health authorities for years. Every time a public health authority has a new idea about the data extraction, they will send a new request to all the providers for them to create a new data extraction with a different format. We don't want that anymore. Only one data format, this one. This is the spec. And let's go with the clinical quality languages. And this clinical quality language has a syntax, defines a syntax and a structure to extract information from FHIR servers for clinical measures. So they will allow you to identify the numerator and denominator for your clinical measure. How many patients I'm caring for and how many of them are well cared. That's the clinical denominator and numerator. So it's also standard. It's a high-level standard, supposed to be written by clinicians. I have my doubts. The use case is apply logic to FHIR for quality measures, for decision support, for instance, for patient gap in care analysis. So this patient has these conditions, these demographics, and these observations. What else should we be doing that we are not doing? That's gap in care. So we can use CQL to identify gap in care. So you can use the URL to see some examples. The language is declarative, is functional, is domain-specific oriented to clinical. It's independent from the platform, the data model, and the location, and it's complete. And this is the way it works. It has a logic and some semantics for the logic, a model behind, which is the FHIR resource model. And for terms, mostly we use SNOMED CT and LOINC. And I think finally we have questionnaires. Questionnaires are FHIR resources and specific implementation guides to define, collect, and store structured questions and answers. This is very common in medicine. Ask questions to the clinician or to the patient and send the responses to the EHR. So for this one, which are the use case? Assessment surveys, governmental forms, patient consent, primary care, oncology, pathology, and mainly report to public health. There are two artifacts for questionnaires. One is the questionnaire resource, where you will find how the questionnaires define the items of the questionnaire, the questions, and it can include value sets, and these value sets can point to reference terminology, for example, SNOMED CT. Usually these are not further restricted, they are the restriction. The question response resource will hold the answers, so whenever an app will fill a question response based on the questionnaire, they will send back to the EHR the questionnaire response. This is very simple. This is the questionnaire with a metadata definition and some items. These items can be nested. Each item has a link ID, the text and item type, which is the data type. It can repeat, and it can have data rules for validation. And the questionnaire response needs to match the structure of the questionnaire. For each mandatory item, it has to have an answer with the same link ID and with the data type corresponding. There are several tools to test and build generic questionnaires. And the answer is very simple when you have the response. This is the format of the response. You can see it's a very simple JSON structure, but all the possible complications remain: terminology control, validation, etc. But it's also powerful. You can specify workflow, simple validation, complex validation, details on how to fill the form and how to extract, convert to or from FHIR resources the response. This is the structured data capture implementation guide, and it defines a series of improvements to the base spec, workflow, request to complete the form, how to find any questionnaire, how to present your forms with any specific colors or formatting, how to define rules or relationship between the items or questions, define minimums and maximums for numerical calculations or also the calculation itself. How to autocomplete on startup with data from the underlying EHR, how to extract data from the questionnaire to other FHIR resources. It also allows to share questionnaire fragments through the use of modules and create adaptive forms built dynamically via an API. Instead of having a whole questionnaire, you can see what question is next question based on the previous answers. Two scenarios for this complete family of tools. One is prior authorization from the Barts reduction family in the Da Vinci project in HL7, which uses CDS hooks to define coverage requirements and the FHIR APIs to get information and exchange questionnaires, and the WHO SMART guidelines by the World Health Organization that transformed their narrative guidelines, which were published in paper, to executable guidelines that can be implemented in computer systems. And I'm 2 minutes from my endpoint. So I will repeat my first slide. I'm sorry, the translators, please forgive me. This is the FHIR toolbox, FHIR implementation guides, smart on FHIR, questionnaires, CDS hooks, bulk data access, and CQL. Pick your tools and make the digital health world go round. Thank you very much.
예, 잠깐 저희가 마이크를 좀 픽스를 해야 돼서, 시간이 좀 제가 끌어야 될 것 같습니다. 너무 H7에 대한 강의를 조금 더 길게 할 걸, 너무 아쉬운 생각이 들고요. 이렇게 많은 thank you for you preparing the 100 pages for us. 네, 다음은 저희 스노메드 인터내셔널에서 또 임플리멘테이션 서포트 팀에서 2분이 발표를 준비해주고 계시고요. 첫 번째 연자는 알레한드로 로페즈 오소르니오이시고요. 앤 호엔이 같이 발표를 해주시기로 했습니다. 저희가 좀 시간이 좀 지체가 되어가지고요. 스노메드 시티 인 더 EHR이라고 해서 EHR 안에서 어떻게 하면 이 스노메드 시티를 잘 임플리멘테이션 할 수 있는지에 대한 서포트에 대해서 잘 발표해 주실 것 같습니다. Thank you. 큰 박수로 맞아주시기 바랍니다.
Yeah. Thank you very much. Thank you for the invitation and
seminar. We are going to review very quickly. We know there's a panel later. We know to give enough time for the panel, but we're going to review very quickly some technical aspects of implementation in education. Yeah. Okay, thank you. Let's go back. So we're talking about the role of SNOMED CT. You heard a lot about this in the previous presentation. This is going really well. Everything that we are going to say is more or less already described in practical implementation. So we are going back to the theory at the end. So SNOMED is a global terminology that tries to add meaning to the clinical record and contributes to ensure the quality and consistency of health delivery. If you want to document clinical practice with great detail, with high expressivity and a broad scope, like Charly, Otero mentioned before, like charts described in Barts Health and everything. And we want to be able to do that using a complex terminology. Yes, we have a very large terminology that needs to be implemented into well-designed system to get the best advantage out of it. So clinicians use SNOMED through the systems, through the EHR systems, and the end user experience varies a lot, and the level of integration is determined by each different EHR implementation. So the success of the use of SNOMED depends on the architecture and how SNOMED is implemented in the system. Usually health records are the applications that store the patient data that contains the clinical information, the signs, symptoms, diagnosis, procedures, and everything. And usually, like Charly Otero described before in Hospital Italiano, the terminology management is separated from the health record in a different system, which is a terminology server. Yes, and most terminology servers today use the FHIR API that Diego described just a minute ago. So in SNOMED CT-enabled terminology server is the one that stores the codes, the term, the knowledge graph, the subsets and maps, and has all the utilities that the health record would use to interact with the user, to facilitate the user access to SNOMED, like searching for concepts, validating the concepts, translating, using maps and things like that. So this terminology server is the key, because having a terminology server allows different tools to share the terminology server, and it can be reused to scale properly. And also the maintenance of the terminology to the latest release, for example, is centralized in one place, and everything is updated for all the client applications. Using the health record and the terminology server, there are different use cases. Today, we will focus in two, in search and data entry, and Anna will describe data retrieval and data analytics. Yes, these are the two parts that we want to describe today. In the search and data entry part, we need to, like Charly was describing before, we need to make the doctors feel comfortable. We need to use the language and terms that are recognizable and understandable for the doctors, for the nurses, for everyone in the health team that needs to record information. We need to hide the technical parts from them, like codes or symbols. Yes, we need to show only the relevant options to them to choose from. We need to prevent errors in that way, and we need to consider their preference whenever it's possible. Yeah, so that's why SNOMED has this interface terminology features of different terms, synonyms that can be translated to many languages, and these are the terms that are displayed to the users. And different users may have different preferences and choose different terms, but they will all use the same concept IDs. And this is how it simplifies the access to the users. Also, SNOMED CT has these complex identifiers that are completely meaningless, and that's on purpose because this makes the terminology more dynamic. But that's why we usually hide those identifiers from the users. The users don't need to see these long numbers, but those numbers are stored in the system, and those numbers are the ones that are used for storing the database, for analytics, and for query and for exchange. Its interoperability is based on the concept identifiers, but the screens show only the human readable terms. And about the only options being available, we need to simplify the interactions of the users. We want to reduce the time required to search and identify values. Yes, we want to mitigate the risk of capturing unintended meanings. So that is why data entry should be constrained to a specific type of SNOMED CT codes depending on the use case. So let's say we want to record diagnosis or results, then we want to pick information or restrict the search of the user to clinical findings. And if we want to record procedures, tests, therapies, or follow-ups, then we can restrict the procedure hierarchy of SNOMED. Or maybe we're recording social circumstances, and there's a special section in SNOMED for social context. So data entry is really important to be very well customized to facilitate the user design and try to consider simplicity and speed and preferences. So in SNOMED, you can either use a search field, you can use lists, you can use checkboxes, you can use radio buttons. Depending on the type of data that you're looking at, sometimes one is preferred compared to the other. For example, an input field in which you can search can be restricted by a rule, and you can, oh, sorry, I need to go back now. And you can search those things. So in these cases, you have different search fields, and each one of the fields, they look the same, but they have different restrictions. So the diagnosis field looks for diseases, the procedures field looks for procedures, the surgical procedure for surgical procedure. So this is what we call terminology bindings, and this is what you can do with the terminology server by sending a query, which is an ECL query that is an expression constrained language query that constrains the values of a search to a particular domain. So how does this work? Yes, let's say we want to record a new or current diagnostic of melanoma. If you don't constrain search and you just type malignant melanoma in SNOMED, you find all these options. And some of these options are not relevant for the user. Yes. For example, the first option is a morphological abnormality that is like the description of the cellular anomaly, not the clinical diagnosis. The second one is the history of malignant melanoma, which means that it's a past disease that is not active right now. The third one is something that is not happening to the patient, happens to a family member. And the last one is a malignant melanoma. And this is why it's important to restrict search. Yes, when you use SNOMED, you need to implement the screen in a way in which only the right concepts appear. This is not difficult to do. This is really easy if you consider this in advance. In the initial implementations of SNOMED, this was not considered, and there's a very interesting paper by Jeremy Rogers in the UK that the initial implementations didn't filter that in this way, and the doctors searched for temperature and registered an attribute instead of a disorder, instead of recording fever, or drug, and they use an attribute, a self or a substance or a body structure. So this happened in the real world in the time when we were not really aware of the importance of constraining data entry. And the same for UI controls. Yes, we have the power to do all these things, but probably different controls are appropriate for different situations. So if a large set of values for a field, maybe we can use search. But if it's a small value set, maybe we can use a list, or we can use checkboxes. And if it's just yes or no, maybe we can use that for questions. So combining the restrictions in the terminology, the selection of the proper UI, and hiding all the complexity, we can create really powerful applications that can record information in different ways, but always record the same meaning, yes, depending on your preferences, depending on your culture, depending on how it accommodates with the rest of the clinical record. So basically, there are some basic principles for data entry in searching. The idea is to do text-based searches, to constrain the search, to always display the preferred term. There's a UI demonstration, so please, if you reach out in the hall, in the lobby today, tomorrow, on Friday, we can show you the demo live. If you type snomed.org/UI, you will find the interactive demo. It's a simulation of a clinical record. You come use this one.
Yeah, otherwise I will suggest that you attend one of the tutorials tomorrow before noon. Then we're also going to show the UI demo.
Yeah, exactly. So now we'll leave Anne for the query analysis part. Let me put them with that side.
Thank you very much. So just let me make a final comment to Alejandro's presentation. So I think it's important with the search and data entry part to recognize the fact, because many people coming into the SNOMED community and looking at SNOMED look at the SNOMED CT browser.
And that's just one interface, and that's relevant to all of us implementing and trying to understand what SNOMED CT is and how it works and how concepts are defined. But for clinical data entry, that browser that's not the intended usage for that browser. So it's really important that as part of implementation, you consider how it can best be integrated into the clinical practice and the clinical workflow. So I hope that that point was made clear. But now let's talk about query and analysis, because one part of it is to get data into the systems and into the data storage. Another thing is to actually utilize that data. And we've heard about FHIR, how we can use it to communicate and how we can do population analytics. But let's just spend a moment to think about how is it that SNOMED actually supports all of these use cases. Charles showed us the feature of, or the concepts for the elephant man, the disorder. But why is it that's important that that's modeled correctly to support analytics? Let's look at a bit on that. So for example, if I were to do analytics and I want to find out what is the diagnosis of a patient, well, I wouldn't even need a terminology for that, right? I just need to know where in the data store I had the value for the diagnosis, and then I could retrieve that. So I just need to know my information model, know where in the data store we have stored the diagnosis. So that's not where the terminology becomes essential. Similarly, if I wanted to find out, well, does my patient have a kind of infectious disease? That will require me to understand the meaning of the concept that has been recorded. Or if I wanted to find all the procedures that have been performed on the cardiovascular system. So for these types of questions, it's not enough just to know where to find the information. It's also important to have efficient ways to interpret the meaning of the various diagnoses and procedures. So if I wanted to find out if the patient have a kind of infectious disease, okay, I will know that I will have to grab that diagnosis that has been recorded. So I can do that by the health record storage structure. But then I need to analyze that and figure out, well, does all of these diagnoses, which of these diagnosis codes actually represent infectious disorders? And that's where the terminology becomes very important. Also, if I wanted to figure out, well, have any procedures been performed on the cardiovascular system? Well, then I needed to get all the values from the procedure field and analyze that to figure out which of these procedures were cardiovascular procedures. So as soon as we start to ask explorative questions on our data, we need a terminology to support that and to do it efficiently. Because for all the different procedures that have been performed, we then need to ask the terminology server, well, which of these codes that we have here present cardiovascular procedures? And that's where we need the structure of SNOMED CT to help us find the cardiovascular procedures. We have a query language in SNOMED, and that's not the CQL or other QL, it's the ECL language, expression constraint language. Because of the way SNOMED CT represents defining properties of our concepts and have the hierarchies, well, we have the opportunity to generate this computable language that can allow us to efficiently query the terminology. And I'll talk a bit more about that later. So this is really just to show where SNOMED CT fits in the life cycle of clinical data, and it fits everywhere. So from the point of data entry, where we report or record the clinical data, we perform research, we perform analytics to obtain new clinical knowledge. That new clinical knowledge is adding to our overall knowledge resources. And those knowledge resources can be disseminated in various ways, maybe by peer-reviewed papers. What are the newest evidence in a certain field? Clinicians will learn and the clinicians will understand, and the clinicians can apply that to provide even better care and treatment for the patient. But that clinical knowledge can also be embedded into the electronic health record through intelligent clinical decision support systems. And for each of these steps in the knowledge cycle, well, SNOMED CT plays an essential role. I have some animation thing here. Well, now we're going to look at the research and analytics. And I hope the next part of this talk will really show you why SNOMED CT is powerful, and by far the most powerful terminology in terms of querying clinical data efficiently. This is a concept, and that's the concept pneumonia. That sits in the SNOMED CT polyhierarchy through a range of ISA relationships. So here you can see, and the reason why it's dotted lines is because there are, if you look at the real hierarchy, there are many other intermediate concepts. But just looking at this, we can see, well, pneumonia is a type of disorder of lung, it's an inflammatory disorder of lower respiratory tract, and so forth. Other concepts such as colitis, appendicitis, pneumonia, bronchitis also sits in the SNOMED CT polyhierarchy in the same way, having a range of other supertypes as you see them here. But this subtype hierarchy is really one of the key features when it comes to analytics. So as you can see here by these ISA relationships that these lines represent, well, all of these concepts are actually kinds of inflammatory disorders. So if we are starting to record data with this information, we gain a lot of additional knowledge about this disorder in a format that computers can process. So if we have recorded patient data with these disorders, well, then we can start to ask our data store, well, which of these people have a respiratory disease? Well, then we need to find the respiratory disease concept, look at the hierarchy, and then identify those that have been diagnosed with any of these concepts. For decision support, this is the principle. We could ask, well, does this patient have a lung disorder? And we would find the concept disorder of lung. We will review all the supertypes of the concept that the patient has been diagnosed with, and we are able to say, no, this current diagnosis is not a type of lung disorder. So those examples shows how the sub-polyhierarchy and the hierarchical structure of SNOMED is useful. But now let's explore those defining properties and what really, where all the quality or a lot of the quality in SNOMED CT sits, the explicit defining properties. So here you have 8 concepts. All of these concepts have been defined with the finding site relationships to various kinds of body sites. So colitis and dysplasia of colon has been defined with a finding site relationship to colon. The next 2 have a finding site to the appendix structure, and the next 2 to the lung structure, and the latter to the knee structure. So all of these concepts have been defined with an explicit relationship pointing at these body structure concepts. And the top 4 concepts have another defining property talking about the morphology of that disorder. And all of these, the morphology for all of the top 4 concepts here is an inflammatory morphology. And you can see for the bottom here, well, the first one has a morphology of dysplasia, the next 2 of fibrosis, and the last of abscess. So this is why you can see SNOMED is not just a set of hierarchies, it's actually a huge network. And this network really represents clinical knowledge, clinical meanings. And this is very useful when we want to query and analyze our data. For example, if we wanted to ask, well, which of these people have a disorder located in the colon structure? Well, now we can actually say, well, give us all the disorders that have a finding site of colon structure, and that will allow us to not only use the hierarchies, but actually use the defining properties to retrieve data. Similarly, with people with a disorder with a fibrosis morphology, again, we could look at the morphology. And that's why we call these relationships that we have for semantic relationships, because it does matter what kind of relationship that we apply. Are we representing the finding site? Are we representing the morphology? What are we representing? So it is really semantic relationships. The process then for performing analytics is to first know what you want to know. So SNOMED CT is not designed with the particular focus in terms of analytics or statistics or anything. Many of the statistical classifications are designed with a focus and use case in mind. Do we want to record morbidity, or what do we want to count the number of cardiovascular diseases or diabetes incidences? We could use a classification, but SNOMED is designed to be useful for all of such scenarios. So first you need to understand what are the questions we need to answer. And that is where the clinicians and data analysts comes in, being able to articulate the clinical requirement or the analytics requirement. So the SNOMED expert will be required then to understand, okay, if that's the question we need, what are the concepts from SNOMED CT we need to derive? And then we need someone who are able to query that, for example, using a terminology server that supports the expression constraint language. So you can see that the thought process that goes into doing this analytics is actually threefold: being able to articulate what you want to know, identifying what concepts you need to query, and then query and execute the query and perform the analysis. And you can use the expression constraint language. It's a computable language, and there's a link here where you can learn all of it. It's very powerful, and it may seem scary if you're not into learning about these computable languages, but actually there are a few features that will take you very far in doing analytics, such as the one you see at the top, descendants or self of the concept respiratory disease, will give you all the subtypes of the concept plus its concepts itself. So let me give you an example, a clinical example, where this could be and why this could be important. We have a demonstrator that shows different scenarios, and this is one of them. And this is really about assessing treatments. So to increase our knowledge within the clinical domain, one of the things that are important is to actually being able to understand how the treatments that we give the patients work. So how effective is the treatment options, and that's important when we want to make a decision about the care path and treatment path. So, for example, if you have a patient that have been identified with a BRCA1 gene mutation or a BRCA1 gene mutation, then because this gene acts as a tumor suppressor or supports the creation of a protein that acts as a tumor suppressor, then you have if you have a mutation of the gene, then you also have an increased risk of breast cancer, and that's evident. It's clinical evidence that there's an increased risk. The problem is that those people who are identified with a BRCA1 gene mutation may feel perfectly healthy, and now they have the knowledge that they have a mutation of the BRCA1 gene, and there are options now. Because of course you don't want to have an increased risk of getting cancer, but if you start to take the preventative medication that is available, well, then you have an increased risk of, or then you have a risk of some very severe side effects, hot flashes, fatigue, that your bones and your muscles hurt. It can be very intruding on the way that your everyday life. And if you're feeling perfectly healthy and those are the side effects, it actually makes very good motivator to actually know what is it likely that it's going to reduce my risk of getting breast cancer. So SNOMED CT can actually help support some research to provide this information. So let us assume that we wanted to do such study. Well, then we would need to first be able to identify patients with a BRCA1 gene mutation, and we could use SNOMED for that. After that, we also want to find out, so who within this cohort are taking the cancer preventative medication or who aren't. And then from those groups, figure out who in those groups got breast cancer and who didn't. And SNOMED CT can be used for all of that. So first we can identify the patients with a BRCA1 gene. So in order to do that, we'll need to find all the concepts in SNOMED CT that represent some kind of BRCA1 gene mutation. Then we want to find all the patients who are taking breast cancer preventative medication. And these three medications are products that the NHS have in their documentation, and these are the kinds of products that they use for cancer preventative medication for patients with BRCA1 gene mutation. And the last one is patients with breast cancer. So there we need to find all the concepts in SNOMED CT that represents a disease with a morphology of malignant tumor of breast. So we transform the question into the set of concepts into the query, and now we're then ready to perform the analysis. And the way that it would work is that, well, first we ask the electronic health record who in our data store has a kind of malignant tumor of breast. So we do the selection. Oh, that's not what I'm doing the first year. First, I'm finding all the different kinds of malignant tumor of breast, and I get that expansion. And then I match that against my patient data store to see who is it. and then I have the patient identifiers. So it's actually very simple, especially if you have that ability to query your terminology store to say, give me all the descendants of malignant tumor of breast. You'll get the expansion, all the SNOMED concepts, and then you can match that against your patient data store. And then it becomes a simple comparison. We have two other scenarios. The one you see on the screen here is for longitudinal studies. So if you have a population data store where you record the incidences and prevalences of different diseases, we can show you how that could look. We have an example that uses 20 years of data. We also have another example about identifying trends in clinical data based on the defining properties of concepts. So I really do advise that you come up to us and we can show you some of these demonstrators that we have available. So I hope this gave some food for thought of why a terminology actually supports both the data entry side, but also actually starting to get some good value out of our data in a different ways that we can do with monohierarchical systems. Thank you very much.
네, 어떻게 저희가 이런 파이어 기술과 스노메드 기술이 이 EHR과 저희 병원 현장에 많은 도움을 줄 수 있고 변화를 가져올 수 있는지에 대해서 유익한 시간이었던 것 같습니다. 그건 한 20분 정도 저희가 또 브레이크를 가지고요. 이후 패널 디스커션을 진행을 하도록 하겠습니다. 다음 세션은 5시 시작하도록 하겠습니다. 감사합니다. 제가 소개 먼저 하고 그다음에 올라오시면 될 거예요. 네, 저희 마지막 순서는 패널 디스커션을 시작할 예정인데요. 이번 토론에서는 한국에서 스노메드 시티 도입과 또 상호 운영성 강화를 위한 도전과 기회를 주제로 다양한 전문가들의 의견을 나눌 예정입니다. 각국의 정책과 병원 현장에서의 얻은 경험을 바탕으로 데이터 상호 운영성을 실질적으로 구현할 수 있는 방안과 요소들에 대해서 심도 있게 논의하는 시간을 갖도록 하겠습니다. 그러면 마지막 이 패널 디스커션의 좌장을 소개해 드리도록 하겠습니다. 오늘 좌장을 맡아주실 분은 임태환 회장님이신데요. 임태환 회장님은 지금 휴먼 텔레레디올로지 센터에서 에미리에이티드 프레지던트를 맡고 계시고요. 그리고 저희 대한민국에서 보건의료 데이터 표준화에 대해서 앞장을 서고 계신데요. 저희 보건의료 표준화 추진위원회 위원장으로서 풍부한 경험을 가지고 계십니다. 큰 박수로 맞아주시기 바랍니다. 네, 그러면 아니면 패널 분들을, 예. 그러면 오늘 패널을 맡아주실 분들을 앞으로 모시도록 하겠습니다. 네, 김경환 교수님 앞으로 와주시기 바랍니다. 서울대학교 홍보학과의 교수님으로 계시고요. 융합위원장을 맡고 계십니다. 네, 다음은 카카오 헬스케어의 황희 대표님 모시겠습니다. 박수 부탁드립니다. 다음은 아까 저희 발표를 맡아주셨죠. 알렉산드로 로페즈 오스로니오. 어디 가셨나요? 스노메드 인터내셔널에 잠깐 나가 계신 거. 네, 잠깐 모셔주시면 좋겠습니다. 또 아까 또 발표를 해주셨던 헨케 쿠만스 부탁드립니다. 네덜란드에서 박수 부탁드립니다. 네, 마지막으로 오늘 발표는 안 해주셨지만요. 저희 패널로 모셨습니다. RPD 스토키에. 네, 그러면 저희 패널 디스커션에 좌장을 맡아주신 임태현 회장님께 마이크를 넘기도록 하겠습니다.
Hi, good afternoon, everybody. I got a question from one of the panel. Which language do you want to use in this session? I think most of the audience are Korean, so I want them feel free, comfortable. So please, if you want, have an interpretation. Okay. 네, 저는 지금 좌장께서 소개를 해주셨는데 표준화위원회를 맡고 있는 임태관입니다. 앞으로 한 50분 정도 디스커션을 하면서 우리가 진정으로 원하는 경험과 지식을 끌어내도록 하겠습니다. 이제 렉처를 통해서 듣는 거하고 이번에 패널리스트들을 선정하면서 각국에서 실제로 느낀 정말 피부에 와닿는 그런 경험들을 좀 들었으면 해서 이런 자리를 마련했습니다. 우선은 이 국내에서는 병원과 학계에 계신 김경환 교수가 계시고요. 그 다음에 황희 교수, 과거에 교수셨지만 지금은 이제 카카오 헬스의 대표를 맡고 계신 두 분을 모셨고, 그 다음에 외국 패널로 각국을 대표해서 한 분씩 모셨습니다. 나와주셔서 대단히 감사합니다. 그러면 바로 시작을 하겠습니다. 시간이 많이 좀 부족할 것 같기도 해서요. 첫 번째 패널리스트는 아르헨티나에서 오신 가장 멀죠. 알필드 스테케님이십니다. 노르웨이입니다. 죄송합니다. I'm sorry. 이 알필드 스테케님은 노르웨이 보건청에서 부서장으로 활약하시면서 스노메드 인터내셔널의 총회 제너럴 어셈블리 의장을 맡고 계십니다. 2015년부터 노르웨이 의료 시스템의 혁신과 발전에 중요한 역할을 하고 계십니다. 이 제너럴 어셈블리 오셨던 분들은 다 보셨을 거고요. 두 번째가 이제 김경원 교수님이시고 방금 소개 드렸고요. 그다음에 황희 대표님 소개 드렸고, 그다음에 알레한드로 로페즈 올소르니오님 와주셨습니다. You're in time? Okay. Now. 자, 오늘의 주제는 The topic today is how can we, Korea, implement semantic interoperability in Korea efficiently and correctly. So we just started a couple of years ago. So we have a lot of things to do and a lot of hurdles, a lot of chasms between the sector. So my question is that, my first question will go to Dr. Kim Kyung-hwan. I'm sorry. You are representing academic and hospital field in medical systems. So my question is in other way around. What do you want in the business sector, industry sector, to do to establish SNOMED CT very safely and rapidly installed in this country as an academic person?
Thank you, Mr. Chairman. First of all, thank you, everyone. And actually, you met me, maybe you participated in the reception 2 days ago. So, and then Kyung Kim from Seoul National University Hospital, and I'm a cardiac surgeon for practice for 27 years, and then I've been involved in healthcare IT for the last 20 years, since at that time the full HIS implementation started in the Korea and the big size tertiary hospitals. So at that time, usually each hospital made their own HIS program. So the vendor was totally different. So actually the physician related or the practice depend, the HIS program was developed. So actually at that time, the kind of standardization or the interoperability or data sharing was not an issue. So at that time, the how to overcome or discard paper chart within 2 or 3 years, that was the issue. But about 5 or 10 years later, some sort of the standardization issue occurred, and actually Professor Park gave me much insight, and actually I'd like to emphasize proposed our business part or government part, because actually it is the program should be focused on the how to the check or the fit the physicians or the medical personnel's the mode of action or the mode of thinking. So actually the good example from the hospital Italiano Buenos Aires, as the Charly already introduced us. So actually that program is the when physician type the medical recordings, usually free text. So the 2 or 3 words later, some kind of the proposal, like what is the etiquette term for this the sentence or a phrase or a word. So physicians should check the word. And sometimes the not fitable or the AI cannot check the free text. So maybe that also should be incorporated into a kind of data. So maybe someone can analyze. So actually in Korea, so the practice, so-called the volume-based practice, I mean the behavior-based, not the value-based practice. So now we are in the we are changing period of the mode of the medical practice. I mean the volume-based from volume-based to value-based. So those kind of endeavor, I mean the put the SNOMED CT code or matching or the standardization of the patient record or doctor's free text, that kind of the actions can make a great role to be the value based practice. So actually I think the one of the important things from business part is the actually the deep discussion or deep dive into the real world, the practice or the hospital areas. So the discussion or conversation with doctors and nurses and pharmacists, and what is important and how to implement SNOMED CT or kind of coding system into HIS, because the too complicated, maybe usually the many people do not like it and do not use anymore. So, and another thing is the government-wise, the government should give the us, I mean the hospitals or the business areas, the big support, because actually those kind of things, government support is very important, and if support is not sufficient, usually many people, many medical personnel not so interested in the standardization or the data gathering or data sharing. So that's current the status of Korea. So the one thing I'd like to emphasize was the example from the hospital Italiano, and some kind of AI-based implication system, and then business part, deep diving, and the government endeavor or big support. Thank you.
Thank you very much, Dr. Kim. And he mentioned about the government support is very, very important. That's because Director Shim is sitting in front of him. And my question again is that business sector never move if there is no money, no profitable. So how come we make them move? One more question to you. A person from a hospital and as a professor?
Actually, I think we should remind the example from the Obama project or the other countries, the contributions to the standardization or the set up the hospital information system. So actually, so far, the implementation of HIS or maintenance of HIS system or upgrade software or hardware, maybe as far as I know, I don't think government gave us any support or actually the invest. Rather than actually based on our medical insurance reimbursement system, I know it is very difficult to get reimbursement from those kind of things, but actually now we should start some point because from now on we should focus on the medical value or patient values, and then gathering the standardized data and open to public. Those kind of issue are become bigger and bigger. So actually it's time to get great invest from government or great decision from government. After then, maybe the business part can move, and actually the medical personnel are doctors and can move. So that's my opinion. Yeah.
Yeah, I agree. Later, not in a long time later, very near later, we must have a milieu of free market concept for the business sector to be involved in this project. So government's aid is only at the beginning stage, limited amount of money, limited period. So I believe that. Now, Dr. Huang, what is your opinion regarding this issue as a director of?
It's really tough questions for the private sector. I'd like to start my answer to your questions with a small piece of my memory. In 2006, as you know, Dr. Kim sponsored lots of, hospital IT system in SNUH and also the other affiliated hospitals under SNU Medical School. In 2003, the SNUH for the first time subscribed the SNOMED CT membership to use the SNOMED CT as a backbone standard terminology for the clinical practice. Then the hospitals were, offended a lot of the other, systems or some vendors, even from the political field. In 2006, actually the parliament called the president of the SNUH to explain the reason why National University Hospital chose the SNOMED CT as a standard terminology tool rather than the local terminology set. At that time, there is a confusion between the SNOMED CT is a more inclusive standard terminology to facilitate the interoperability between hospitals or cross, industry, like between hospitals and the pharma companies and so on. So today, the South Korea and Ministry of Health is now hosting the SNOMED CT Expo in Seoul. finally. So I think what I'm saying is that there are so many progress for past 15 years in South Korea, and all of those kind of progress is actually attributed to the hospitals' efforts, such as the leading hospitals, SNUH, Catholic, Severance, and Korea, and every hospital's effort. But we are now facing another problems, how we can facilitate the SNOMED CT as a catalyst tool for kind of some multi-institutional research or some kind of, business models from the perspective of the private sector. So basically, regardless of the type of the technology, such as AI or like the LLM or IoT, whatever we say, the in healthcare sector, business model can be set up after the value creation. So if we can explain how we can make additional values in terms of the clinical outcome or in terms of the enhanced kind of some efficiency at the operation level, then we can say that we build the kind of some business model, even if it is very weak or very, kind of some hurdles. So basically, before the mentioning about the business model, actually we need to make a consensus between hospitals and the companies and even the government sectors, what kind of values we are wanting to create through the SNOMED CT. Actually, as the kind of some expertise in this field, I got numerous questions from every new directors from the ministry. Why the government support the SNOMED CT adoptions into the hospital or into the industrial area? But everyone now see that each countries in EU, United States, the standardization protocol is a kind of some background for the research or business or some other values in the clinical outcomes and so on. So it's actually the government duty, I can say, after the kind of some making the background for the hospitals and the private sectors, then we are going to make some interface between the different kinds of the players at this field. For example, at the Argentina hospital cases, we saw that how that kind of wonderful hospitals are utilized the new technology such as natural language processing or the large language models, even the generative AI in a recent manner. But conventionally, the SNOMED CT mapping requires too much labor-intensive effort for the single hospital. From the single hospital's perspective, there is no reason to use the SNOMED CT for the independent clinical research. SNOMED CT's value is really existing in the interoperability, from the perspective of the data, scalability, expandability, and especially when we think about the increasing needs or demand for the real-world evidence for creating a new, evidence for the clinical research from the scalable data between each hospitals, multiple hospitals, then in that case, is actually every hospitals under the Ministry of Health in Korea is mandatorily, use the SNOMED CT or some other, international standard for the collaborative research, and then finally, hopefully, create the extra revenues in addition to the clinical practice. That might be the final purpose and the end point why the hospitals, government, and the private sectors are working together for this kind of, very difficult, the methodologies in terms of the standardization of the terminology. So that's the reason why this symposium is also handled the FHIR protocol as a kind of some transfer the data after the standardization of the terminology. So we actually on a right track in South Korea cases. We set up the KHIS, and also we set up the kind of some committee under the ministry, and we set up the KR-CDI, we set up the KL core, even if the status is so primitive now. But I think we are now on the right track in advance of the other regions or other countries. So we have great potentials to improve the lots of data standardization, utilization. So we have to focus on the data reutilizations after the interoperability.
Thank you very much. Very thorough review. And then I basically agree your idea. But I have to listen to Dr. Coomans because he gave us a lecture that the Netherlands system is very stable. That's what I felt. And then in that context, this Dr. Kim from academia, Dr. Huang from business sector have a little bit of different idea. And what do you think is the government's role to settle down this system, including the population agreement? Okay, could you give us some advice?
Yes, I think I touched upon some of that in my presentation already. The government, excuse me, the government has a unique role in the whole ecosystem in that they are what we call system responsible. So there's a political responsibility for the operation of the entire healthcare system. So that is sort of like the problem owner of interoperability is the government because it is for the public. And in that sense, to be able to handle that responsibility, the government needs to show its leadership, and through that leadership, build credibility with the programs that they are investing in. And I think that's what's been going on here as well. And through that credibility of being able to address real issues in the healthcare system at that system level, you can build authority. And I think that's the growth path that you need to have as a government. We try to do that, build the credibility through what I showed as the carrots. So through throwing a lot of money at all the people who are involved and allowing them to go through their own learning curves, because it is incredibly complex matter. So it is trying to, what we call then, trying to build an airplane while you are flying. And that's very difficult to do, I can imagine. So it is, you cannot stop your healthcare provision to build something new and then start over again. So you have to keep everything going. You have an immense pressure on your resources, both financial, but especially in your workforce and the talent that you have. So it is very complex to be able to do that and to think through of all the consequences that you have. So as an authority, you can build your credibility by engaging, of course, with all the stakeholders. Now, this is too much of an open door because engaging with all the stakeholders is listening to everyone. Everyone has an opinion, and if you ask them the same after a meal, then they have different opinions. So it's very difficult to come to that consensus. So we try to do that at 3 levels to get the engagement to build our credibility. First is that you build knowledge, so everyone knows what they're talking about. So that's training, that is education, but also just marketing and showing the benefits of these standards and these programs that you're using. Then you have to allow them, all the different stakeholders from private sector, from academia, from healthcare providers, professionals, patients, funders as well, by the way. You have to allow them to get an opinion about what does this mean for me. So it's not just knowing about it, it's also knowing what is the impact on my business case or on my process or on my purpose even. The third one is then to give them options of desired behavior. So it's not just knowledge, it's attitude, and then you have to change their behavior. And that's something that you can incentivize with those carrots that I talked about. And then finally, as the authority, you've built enough credibility then to legislate this. And that would be the final step. It's not you have to do this because it's law, but it's because you've decided as a community that this is what is required at the system level.
Thank you very much. And I believe that there must be some market theory afterwards. It's stabilized. Vendor side and hospital, doctors, there must be some market theory functioning. Only the government is functioning is at the beginning stage, I believe. But as you have a stable system, as far as I know, now what is the role of government nowadays? Let's rate it 100%, 0%, now 50%, 60%?
So there's politics that sort of destabilizes. So you always have some iteration of involvement. And then the space of development of the technology is going so much faster than anyone else can keep up with. So your market space is going into places where you haven't been able to establish that stability yet. So I think the role of government is also to expand the market in that stable sense. So that means there are rules and regulations and incentives in place to work with things like generative AI or proton therapies or other novel therapies. And so the marketplace keeps expanding, especially with the exponential pace of change that the technology is bringing right now.
Yeah, thank you very much for that. Dr. Stockett, I have a question to you that when you have tried to establish your system in your country, Norway, what do you think is the most important collaboration, international collaborations? And as a startup, Korea, how can we get some information, experience sharing from the other countries? What is your experience?
Yes, well, thank you very much for having me. So, all right, now I'm the chair of the General Assembly. So I think obviously that's one of the things that's very important for us in the SNOMED International, that we also have this General Assembly, and then we can, share different thoughts there. But that's on a different level. I'll just start by saying a couple of things that has been going on in Norway. So I am the Directorate of Health in Norway, and so I'm a head of terminologists, and they have been working almost like 6 years ago. We started a big program to see how can we go into from the government side, how can we go into getting the codes and classification to work a little bit better together with we decided to go into SNOMED International. And one of the big successes by doing that when we have this big program, we had a lot of funds coming this way. So we also instead of saying, okay, we're gonna fund the big delivering the health systems, we said, okay, we're gonna fund instead the standardization side of it. So we started to fund getting into not paying for SNOMED, but paying for standardization and mapping. So that when you when we get into Norway, there was also mandatory to use the standards, and then also using having that funds. So when you talk about when Herko Coomans are saying the carrots, so the carrots here was to funding the standardization part of it, not the actually getting any things to the delivers of the systems. So that's what was very one good thing. Other than that, I say that also in the mid of Norway, when we were doing this big implementation, we see that some of the things we are struggling with and other things are going very well. Some of the things that are going very well is like the big catalog in that's now the medicine catalog is now using SNOMED codes to verify, and then that also gives an interoperability around all the different systems. The second thing that I would mention is the nursing systems, because we have care plans for the nursing systems, which is also been a big successful thing in Norway. You know, there is a lot of doctors that's very interested into SNOMED, but actually there is much more nurses who need to have the care plan into the system. So that's one being a very, very successful story. Other than that, also being a part of SNOMED International and getting all the things back from this international system has been a very also a successful story for us. So we're getting in, for instance, I can mention which one, and that is to get translation done well. So that's been, you know, since we have a different language, and it's been maybe a little bit hard for before in the start that SNOMED International had a lot of English speaking, but now I think when we are so many countries now who really need translation, so that has been a very big story. And then we also have been using, we've been a part of sharing those committees to even get the knowledge from to all of us in the Norwegian region, but also to be to get people to be very interested into Norway, into SNOMED, and to make that translation. So that's a couple of things to think about. Yeah.
So in your country, most of the doctors use Norwegian language or English?
They use Norwegian language, yes.
Yeah. Any problem
well,
in using SNOMED into EHR, SNOMED enable EHR?
Yeah, good question, because that was one of the things that we used a carrot for.
Mm-hmm.
We were actually paying for the translation. So the translation was done with the doctors, with the nurses, and make sure that it was qualified, good translation, but also the payment from that coming from the government.
Mm-hmm. Mm-hmm. One of the purposes of using SNOMED in the future is that the communication between the hospitals and institutions, as well as between the patients and families. So we must have a way to communicate with them. So that's why I asked that. All right. And thank you, waiting a long time, Alejandro. So you gave us a very wonderful lecture today. I would like to ask you a little bit of technical issue. So in the beginning, as Dr. Kim told us, that we have using many different type of EHRs. Now in Korea, big hospitals have their own EMR system or a big vendor provided EMR system, not interoperable. So when they are thinking of change the EMR system, that does mean that the several millions of dollars to change the system. So I would like to know your experience. Probably you have the same experience, but what did you do when change the system totally overhaul, or what is your experience?
Yeah, it's a really interesting questions. There are different options. In general, it's possible to overhaul to a certain level. So many systems can start working with mappings, for example, if they have local terminology. Sometimes the first thing they can do is to map their local terminologies to SNOMED and just start to be functional in a SNOMED environment. Of course, in the long term, you prefer to go to a native implementation of the full SNOMED standard that provides more detail and more flexibility. But that can be done like in the transition. And sometimes systems can be updated to include the complete SNOMED without starting the system from zero, without replacing the whole system. But it's difficult to motivate to start doing that change because, like you say, these are expensive endeavors. And Herko commented a lot about incentives, and that's really an interesting way how you can incentivize them to start moving. And I want to complement that with diminishing barriers. Yeah, so once they start moving, they need to move smoothly. They need to have no challenges and no complications when they start to implement. So I think there's a role also on the government side to provide a smooth process for using SNOMED, to constrain SNOMED to some use cases, not to do everything at first, just select a few cases like Herko said before, provide support and training for using terminology services, maybe some open source tooling, maybe some national infrastructure to support exchange or to support mapping or to support transformation. So there are ways to lower barriers, to simplify the adoption process. So when they decide to start moving, that goes really fast, well, and smooth.
The eternal goal is that we want to use one single language in healthcare system and in medical system. I don't know if that will be possible in the future, but our goal is that. But as Dr. Dr. Gutteridge, Charles Gutteridge mentioned during his lecture that it's never-ending work. So probably until the end of universe, it will everlast, right? Okay. And the other lecturer told us that we should be in a step-by-step, not one elephant in one time. That's also I agree. But it's easy to say, but how can we handle that? Everlasting, step by step. There must be some funding, people, expert. So as a beginner, we Korea really have some enthusiasm, but I believe in the future we can make it. And now we have some time, so I would like to get some questions or comment from the audience in the floor, or the panels, you can give us some lecture each other. Any questions from the floor? Yes. Please identify yourself first.
I'm Dr. Bunchai from Thailand. Korea is very famous on the universal healthcare coverage and very strong the national health insurance system. We talk a lot about the carrot and stick. How well we can engage those kind of the financing system to incentivize the doctor provider to adopt the SNOMED CT. I think that would be a very strong incentive.
Yeah, thank you for the question. Who's going to right person to answer this question? Dr. Huang, do you have any idea? Okay, but I know that Thailand has also very excellent healthcare system, as a kingdom, yeah, I have once visited and see the systems very nicely working. Okay, Dr. Wang?
Yeah. Actually, I'm not the official people from the ministry, so it's not the official answer to your questions. It's a kind of some perspective from the long working hospital and the private sector's opinion. Yes, the South Korea has very strong systems for the national single insurance system. It's really good. And actually, that is the one of the biggest hurdle why the SNOMED CT or international standard code is not yet spreaded, because for the reimbursement process, actually South Korea established a really advanced manner in 1997. We established the EDI code systems for the reimbursement, and then it's a little bit modification was done, but still we're using the EDI. So from the perspective of the hospitals or some provider side, there's no reason to use the other international standard code for the kind of some prevent the rejections from the reimburse or some kind of. So that's the reason why ministry decided to approach to spread international standard code, including SNOMED CT, from the stepwise from the EHL validation programs for the first time in 2019 or 20, yeah. So the government aims to deploy the standardized EHL programs for every hospitals, regardless of the type of the practice in Korea. Maybe it will take the 10 years or 20 years, but at least for the research-driven hospitals, tertiary hospitals, and university hospital cases, it really effective. So, because within the validation criteria, it's not yet mandatory, but if the hospital adopts SNOMED CT mapping into the local code, whatever kind of some backend or some front end side, in that case, is the ministry will consider the kind of some incentivized programs for that kind of job. Of course, yes, you're right. If those standard terminology set is combining and aligned with the reimbursement system in Korea, it might be very super, powerful to adopt the standard code systems so fast manner, but it will take a really lots of troubles to change the 25 years, the kind of some conventional way of reimbursement process. So from the perspective of the long-time hospital working person, I really hope to reflect that kind of standard code systems like SNOMED CT or some LOINC, or for the medication code systems will be reflected into the kind of some reimbursement status. But I think I can say that in Korea, we are now step forward moving, even if it's a little bit slow. So basically, we started that kind of change.
Okay, Dr. Kim, you want to add something in this issue?
Yes, it is very difficult to answer, but actually I'd like to mention one of my experiences. About 3 years ago, my project was nationwide the patient blood management system platform, the launchment. Actually, the purpose was the adequate transfusion, how to save blood, and maybe traditionally the blood saves people, but now by evidence, blood can harm people. So that's why the patient blood management project occurred. So actually, we made the system, and actually the proposed the Minister of the Health and Welfare, and actually we can launch those systems in whole HIS systems, but actually the government has some reluctant at the mode. So maybe if those systems, actually those systems are based upon the SNOMED CT and HS75 standardization systems, coding and interoperability. So it can check the nationwide transfusion and actually Surgeon Kyung Kim, in the year 2020, how many transfusions he did and how many the patients died or something like that. So actually maybe some resistance from the medical personnel or the doctors, but those kind of system and based upon the standardization plan, the SNOMED CT or HS75 and the national system can make actually the benefit or the safe effect to public or people. Maybe after that, our government will consider any incentive or the big investment. That's our opinion. Yeah.
Okay, I think we have lost our way a little bit. So we must go back to SNOMED CT. And Dr. Coomans, I would like to apologize that I didn't mention your name when I talked about the step-by-step. Dr. Coomans, it was you, right? Mentioned that
Yes.
we need step-by-step approach.
Yes.
So my question is, to have your kind of very stabilized system up to now, how long, how many years has taken to your country to be here?
Yes, we joined SNOMED in 2007. We were one of the founding members. So essentially, at least since then. And like Dr. Gutteridge said, it is something that requires a lot of stamina. So this is something that we need to understand, that it is complex. It's not a technical problem. This is very much a change management problem in a fast-moving world. Every time we learn something new about biology, about diseases, or we have something like an epidemic, there's new incentives, new pathways that you want to explore. And especially, for instance, like with the pandemic, we all learned that our health systems were not up to the task in some way or another. And we learned that international collaboration is the only way that we can do this in a sustainable way. So I think that those two things really help now for the business cases at any level, at government or at healthcare institution or at funder level, that there's a bigger sense of urgency, and on the one hand, and on the other hand, that there is technology and solutions out there that can actually do this at scale. So instead of, I think we're out of the era of exploration and discovery, and that we are now entering the era of application and starting to not just define the added value, but actually reaping the benefits, even at small scale still, but reaping the benefits of doing all this work. But I think, like Dr. Charles says, it's going to be quite a long time until everything is done. But we have a very limited understanding of how our body works already. So there's still so much more to discover there.
Okay. Yeah, thank you. So we need more communication in the time ahead between Korea and your country to learn the real practical way to establish the system. And Dr. Alejandro, probably it's a silly question, but I know that your hospital Italiano is very good for this interoperable, SNOMED CT and informatics. How is your whole nationwide system, the other hospitals and?
In Argentina. Yeah, Argentina is lacking. Charly is the expert from Hospital Italiano, but I can answer about that because I worked with Charly for many years and I was in charge of Argentina's digital health strategy for a while. And it's challenging. It's similar to Korea. It's one of those countries where the private sector is important and there are a lot of freedom and the hospitals can do whatever they want and they can make their own decisions and provinces. So yes, coordination of efforts and alignment is really difficult. But starting with explicit goals, like a clear agenda that everyone can read and can see a direction, like gaining, like Herko was saying, gaining credibility, so you can explain where this is going in your country. So anyone who is trying to do something, sometimes they look for a model, they look for a direction. So if you are there to present them with a direction, sometimes they adopt that, and that aligns the will of different hospitals and people.
All right, thank you. Sorry for mistake that I made about the hospital name. And Dr. Charles Gutteridge, I did my best to pronounce your name correctly. Is it right? Gutteridge? Gutteridge? Oh, well, thank you very much for that. And any question from the floor again? Only one person. Yeah, Professor Park.
So as a person who is working on in and around the SNOMED city in Korea, I think this is a miracle. Just have this meeting here with all these people coming from Korea and from other countries. I think it's, to me, it is a miracle. So I thank you for that, Director Shim. And if you hear all the models of different countries, Argentina, it's more like a private sector initiative, initiated a kind of model. But Netherlands, because you joined SNOMED International as a founding member, so you are more like a top-down kind of, you are implementing top-down kind of approach. So I kind of reflected where Korea is. So it is some way it's like Argentina, but I think culturally we are so used to, hear something from the government in order for us to move. So I think we should have a kind of model what the Netherlands implemented, but I think we need a lot of use cases, how you guys did it. And so I think this is just a good opportunity for, not me, for our officers from Ministry of Health and, learn how you guys did implement the SNOMED CT in Korea. So I think this is just a super duper opportunity for us so that we can engage more with the Ministry of Health, in the future, so that private sectors and industries, they kind of look up Ministry of Health and see, please, what should we do? So this is kind of a model that I was thinking. Another thing I was thinking is that because we have so many health IT initiatives going on, so if we can just drop a little droplet of water into that health IT initiative, I think that will make a big change. So I just would like to thank you guys.
So it was your comment. Thank you very much for that. And in Korea, there have been a miracle happening because only 2 years ago, I didn't know nothing about SNOMED. But 2 years after now, I'm chairing the session. It's real. And any panelists ever raise a question or comment?
Yes, I'd like to comment also on what Dr. Park said. we are also, and Steve Posnack, the American, he's got a new title, but from the American Office of the National Coordinator for Health IT, he also said this in his presentation on his video. There is also a group of governments working together on all these questions, which is the Global Digital Health Partnership. Korea is a member. Australia is sitting there, is also a member. The Netherlands is currently chair of this forum. And we deal with exactly that question of what should governments do? What is our approach? How can we learn from each other's successes, but more, you learn more from each other's failures. And it's a safe space, it's government only, so everyone there understands the problems that we all have. Because it is challenging to be in this space with all these pressures from all sides. And the ask of government is, well, we just heard this today in this panel as well. It is good to have a good engagement with government and that they can find answers in many places.
Right. The stance of government is one of the most important things to have a good system in the future. And one other thing that I would like to mention is that the SNOMED CT International's role, it will be the really important one. Dr. Stokke, I have one last question for you. Probably all of the audience would like to know that. How rapidly develop this SNOMED CT in terms of member country, in terms of budget? Can you give me a ballpark?
Oh dear, that's
Right.
the hard one.
Because you're chair of General Assembly.
Yes. Yeah, no, rapidly, I mean, you could see that we have expanding very rapidly. And now I'm talking as the chair of the General Assembly. So when we started from Norway side, we were, I think we were 22 countries. And right now we are 50. So that's we started in 2017, I think. So, you know, it goes fairly quickly. And but then again, we came to a stage in SNOMED International now that the largest country when it goes to GNP is already there. So it's also other issues now. So the other issues are how in General Assembly we'll be discussing, you know, how is this expansive? Are we going to go to try to grow more in another way, you know, and there's a lot of discussions going on that. So I think I'm just going to say that, and then I think that it's a healthy organization, and you can see now that it's a very good community. So the community will actually are expanding. So even if we are a few members, all that we do with the terminology will also expand and get more people into working with this. Mm-hmm. So that's one of the good things about being a member of SNOMED CT. Yeah.
Thank you. Now time's over, so I would like to wrap up the session, and I thank you very much for participation, panelists and audience. Thank you.